I'm Michelle Decker, and we're just so thrilled to have this day. I want to tell people a little bit about the Women's Health Research Group. You've got some information in your program, but I want to just give you sort of an idea of where this all came from. This is a group that was founded and is still led by Dr. Wendy Bennett over in internal medicine, and it's really designed to bring together nursing, medicine, and public health, people that are working in women's health. So we host networking events throughout the year. We typically host a mentoring dinner, and then every spring we host a symposium, and we bring in speakers on a specific topic, and we also sort of highlight and really lift up student, trainee research and research by our junior faculty. So we're really thrilled today to really be focusing on women in HIV. And you'll notice that our program really is designed to span sort of the biomedical pieces with PrEP, as well as some of the structural determinants, things that we're all working on, and really drivers of the epidemic, and also truly our solutions, right, to HIV globally for women and domestically as well. Before I introduce Chris Beyer, I just want to really thank, we've got tremendous support from across the schools. The Mid-Atlantic Public Health Training Center is actually webcasting our morning, which is wonderful. We've had great support from the School of Nursing, from the School of Public Health, and also from the School of Medicine in really making this event happen. And of course the CFAR, our Johns Hopkins Center for AIDS Research. So just to really thank our sponsors for this event for bringing us all together in this area. And I think with that, I'm going to introduce Dr. Chris Beyer, co-director of our CFAR here at Hopkins, leader of our Center for Public Health and Human Rights, and of course, president of the International AIDS Society. So thank you for being here.
Well, good morning, everybody, and I'd like to welcome everyone to this event and also to Hopkins, to our guests. Really delighted that this is happening, and I want to say a special thank you and welcome on behalf of two centers. The first is our Center for AIDS Research, which Michelle mentioned, and of course Michelle has been an awardee of one of our Faculty Development Awards for the CFAR. A wonderful thing about the CFAR is that it brings together medicine, nursing, and public health, which is also underscored in this Women's Research Day. And I saw Trish Davidson, there she is, our Dean of Nursing, who's been a tremendous supporter, continues to be a supporter of our CFAR, and we really greatly appreciate that. I also want to acknowledge a special role that Michelle Decker has taken on with our Center for Public Health and Human Rights. So Michelle is heading up a new program within the center. That's our program in women's health and rights. And as she has done with just about everything else she's been engaged with at Hopkins, she has brought tremendous energy, enthusiasm, great scientific capacity and skills, and also her passion for these issues. So we're really excited about the program. It's second year it's been running, I think. Is that right? Only second year, and already yielding some tremendous outcomes, including this science. Michelle came to us from Harvard. We don't hold that against her here, but she has been here a relatively short time and really become just a central member of our scientific community. So we're really delighted about that. I also want to just welcome and acknowledge a dear friend and a close research colleague, Nabila El-Bassel, as we have worked together for a number of years. She invited me to get involved with some work that she and her group were leading in Kazakhstan. And just recently, the results of that are out on a successful intervention for drug-using couples in Almaty. And she really has brought scientific rigor to a place that needed a great deal of research investment. So we're always delighted to have Nabila with us. So HIV in women and girls is, of course, one of the areas where we still really face some enormous challenges. If we look at the landscape in 2015, I think this is one domain where we really have work undone in the HIV response. And there are some really important looming questions ahead of us. Particularly the epidemic among adolescent girls, young women, in southern and eastern sub-Saharan Africa. In those epidemic zones, which of course are the most affected worldwide, you have an enormously female-predominant epidemic, and we have these incredibly high rates of incidence starting very early in reproductive life, 12, 13, 14 years of age, and of course reaching close to a quarter of women by age 25. That is really unique in the world. It's only in that part of the world, and it is really an epidemic that we still don't fully understand, and we are not controlling with our current approaches. Obviously, we have some enormous challenges in primary prevention. I'm delighted to see the focus on pre-exposure prophylaxis here. We all know that we just had the failure of the phase 3 vaginal microbicide trial, for which there was a great deal of enthusiasm after the 2B was the first one to show efficacy, so we are not there with topical PrEP. And oral PrEP in women remains a challenging question of, is it biology that is challenging us? Is it adherence? Is it measurement? Why is it that the findings are so consistent now in men with oral pre-exposure prophylaxis, including very challenging biology of men who have sex with men, consistent efficacy, and these uncertain and difficult to understand results for women? So that, again, is an enormous research area that we really need to focus on. We also, of course, are challenged with some of the reproductive health issues and this ongoing concern about hormonal contraception and HIV and risk in women, and the definitive studies there maybe are going to happen. They're going to be big and complex, but I think it's absolutely critical area. And in adherence, we're seeing the emerging, unfortunately, real challenges with Plan B+. Of course, there was a great deal of enthusiasm for the idea of treating pregnant women, initiating them on therapy irregardless of CD4, offering that to every pregnant woman in sub-Saharan Africa, and hoping that this would carry on through subsequent pregnancies and really improve clinical outcomes. And the data that's emerging on retention postpartum in a number of Plan B countries is a real disappointment. It is nowhere near as good as it needs to be. So even in the treatment area, we still are challenged with how to do better for women and girls. So I think there's an ambitious research agenda. There's a critical research agenda. It's important that happily young scientists, all of you in this audience, are engaging and thinking about these issues. There's still a great deal of work to do in this area, and we're going to need to keep pressure on to keep these research resources coming for women and girls. That is going to be a real challenge in the years ahead, because we are not there yet. I think that's really a critical message. And the enthusiasm around the end of AIDS and AIDS-free generation and all the rhetoric that's out there has an enormous caveat at the end of it. Yes, but we're not delivering primary prevention or the kind of adherence support for treatment that we need for women and girls in the most affected areas, and that, of course, includes our beloved city of Baltimore, as we all know. So I want to wish you a tremendously successful symposium. Delighted to see, in particular, the focus in the afternoon on young investigators. There's a long-haul research agenda here, so it's good to see young faces in the audience. This is going to be going on for much of your careers, I'm sorry to say. And let me just say one last thing, which is the International AIDS Conference. I'm going to have to duck out to do a conference call on the planning for it. But it will be in Durban for the first time back in Africa in 16 years. Durban, of course, is the capital of KwaZulu-Natal. And KwaZulu-Natal is really ground zero for HIV in women and girls, right? The highest prevalence anywhere in the world in these communities. So that will be a major focus of our conference. My co-chair, Olive Shoshana, is a real leader in this area. And so I would encourage you to think about your science you'd like to see there, and participate, get engaged. We really hope that AIDS 2016 is going to be a watershed moment for women and girls. Thank you so much.
Great. Thank you so much for that. I think that's really sort of kicking off our day. Actually, just a couple things that I want to mention before we get started. Just feel free to, please, people are going to be kind of coming and going throughout the day, so if you need to step out, feel free to do so. And of course, you know, part of our Women's Health Research Group, kind of our mission in our culture really is really to promote networking and so forth. So be sure to meet a couple of new people before the day is through. So after that, we really want to lift up sort of where are we in the epidemic? Where are we domestically? Where are we globally? And what are we seeing? What do we need to be attentive to as we think about the intersection of HIV and reproductive health and women throughout the life course? And so that's the idea behind our sort of our first panel here. And I want to just really start off by introducing Dr. Liz Golub, who is going to be sharing with us the domestic HIV update. We're delighted that she's here for many reasons, in part, of course, because she co-leads the Data Management and Analysis Center for the Women's Interagency HIV study. And of course, that is the largest and longest standing, up to 20 years now of follow-up data for HIV-infected and uninfected women here in the United States. So we're so proud to have that right here at Johns Hopkins, and thank you for sharing.
Good morning. I don't know who Conrad Crispino is, but that's mine. Well, thank you very much, Michelle, and thank you to Michelle and Wendy and the symposium organizers for asking me to speak today. I've been a member of the Women's Health Research Group since its inception in 2008, and I'm also delighted to see so many people here with an interest in HIV and women. So I want to talk a little bit this morning about, sorry, looking for a pointer. I'm not finding one, but that's okay. I want to talk a little bit this morning about the domestic HIV epidemic, where we are here in the US, before we launch back into sort of the global picture of where things stand for women and girls with respect to HIV. So, of the more than 1.2 million people living with HIV here in the US today, women and girls over the age of 13 account for 25% of that prevalence. And in the year 2013 alone, there were over 94 new HIV infections among females and over 6,400 new diagnoses of AIDS. So clearly just too many women and girls infected. This map from the CDC shows the prevalence through year-end 2012 among female adolescents and adults by state or territory in the US, and you can see that the darker regions represent the highest prevalence estimates. You can see a geographic pattern here emerging, that there is clearly a disparity, with the highest burden occurring in the northeast and the southeast portions of the United States. Chris mentioned Baltimore, and so just to frame this, where we sit, quite literally, is fourth in prevalence, behind only DC, the US Virgin Islands, and the state of New York. So the burden in Maryland and the geographic disparity in burden persists, of course, as well with incidence. So this is incidence during 2013, where Maryland is not fourth, but we're third, behind, again, DC and the US Virgin Islands. I don't think it's a surprise to anyone here. We know by now that African American women and girls are disproportionately affected, so there are disparities in addition to the geographic one. This shows on the right, you'll see shaded in pink, that African Americans make up only 13% of the female population of the United States, but on the left, sadly, they comprise 63% of new infections with HIV. There are many reasons for this, and this slide is in no way intended to be comprehensive, and you're going to hear a little bit more about reasons for this later on when Dr. Hoover speaks. There are behavioral, structural, social, all kinds of correlates that go along with this. I think one of the big drivers, though, that I wanted to mention is the fact that an estimated 87% of new infections with HIV among women and girls are due to heterosexual contact. This is particularly true for Black women in the U.S., and the prevalence among Black men in the U.S. is the highest of any race, ethnicity, by sex stratum. So just to show you that a little bit more, if you look at infections among women and girls stratified by race, you'll see that heterosexual contact is responsible for 90% of new infections among Black women and girls, but only 74% among whites. And the rates among men, as I mentioned, you can see on the left in pink the rate for African American men in the US, which is more than 2.5 times higher than any other group. It's more than 2.5 times higher than the rates for Latino males, for men of multiple races, and more than 7 times higher than the rate for white men. So yes, this is a symposium on HIV in women, but with so much of the infection among women being driven by heterosexual contact, the epidemic among men should be equally important to all of us. So I've spoken so far about prevalence and incidence in terms of the burden of the epidemic among women and girls, but what do we do, what benchmarks do we use to measure how people are doing once they're infected? So many of you are probably familiar with the continuum of care that we look at to see how people are doing once infected. Are they engaged in care? Are they receiving therapy? Are they staying on their therapy? And are they achieving viral suppression? So in 2011, among women in the states living with HIV, only 45% were engaged in care, and 32% had achieved viral suppression. How does that stand up against the national averages? So this is the US population at the same time. This was published in 2011, and you can see that women are not engaging in care as much as we would hope. So they're doing more poorly with engaging in care. However, once in care, they're actually doing better than the national average. So the issue doesn't seem to be that women don't do well on therapy. The issue seems to be engaging women in care. So that's, I think, an area where we really need to focus a lot of our efforts. So these data are all from 2011. I want to thank Peter Ribeiro and my NA Accord colleagues for providing updated data. So for those who may not be aware, the NA Accord is a collaboration of over 23 HIV cohorts among the US and Canada, and these data are more recent and confirm what I just showed you, showing that women are more likely to remain in care than men once engaged in care, and in fact they remain in care for a median of 6.8 years as compared to only 5.7 years among men. So again, what we really need to do is get women into care once infected. So Michelle mentioned that I work with the WIHS, the Women's Interagency HIV Study, which is one of the cohort studies that contributes to the NA Accord. So I'd like to share a little bit of our data with you this morning. The WIHS was initially funded over 20 years ago, back in 1993. We began enrolling women in 1994 at 6 US sites, 2 in New York, Washington, DC, LA, San Francisco, and Chicago. We enrolled women in 1994 and 1995, and then again in 2001 and 2, and then finally a third wave in 2011 and 2012. You may notice, in stark contrast to the CDC maps that I showed you earlier, the southeastern portion of the US is not represented. As a result, in January 2013, we added 4 new sites to the cohort where enrollment is ongoing and wrapping up hopefully in the next few months. So to date, across all of these sites, we've enrolled over 4,800 women into the cohort. I should mention that among those 4,800 women, approximately 3/4 are HIV infected, 60 to 65% are Black women, and about 1/3 are Latina. So how does the WIHS population compare to the overall US HIV-infected population? Just to give you a little bit of framework. According to the CDC, about 25% of those infected in the US are over the age of 55. The same is true for the WIHS. So this is the age distribution of our current cohort, those who are currently still coming in every 6 months for their study visits. In blue, you see the age distribution for the seronegative women. In red, or orange, the seropositive women. And so you can see that the median age is currently about 49. We match that 1/4 being over the age of 55, and 10% of our cohort is now over the age of 60. Some of these women have been in the study for over 20 years and are still coming in. So we match quite well the age distribution of the US HIV-infected population as well as the race ethnicity breakdown. So on the left, you see new diagnoses of HIV among women and girls in the US for the year 2013. You see 63% African American, et cetera. And on the right are the WIHS actively being seen HIV-infected women. So very similar in terms of age and race to the US HIV-infected female population. So one of the biggest strengths that the study has is over 20 years of data. Women come every 6 months for study visits and provide just a wealth of information on how they're doing. And so we've been able to track the natural and treated histories of HIV over the past 20 years. Two markers that you're all very familiar with, of course, are CD4 and viral load. So here you see in the red CD4 and in the blue viral load over the course of the WIHS study follow-up. For each color, the solid line is representing the women on therapy, and the dotted line represents the women not on therapy at any given study visit. So what I'd like you to take away is looking all the way on the right at the most recent data. The CD4, the average CD4 count for women on therapy is now 600, and the majority of our women on therapy have suppressed viral load. So this is another Therapy Works slide. So with the increase in uptake of therapy over the course of time, we have, of course, also seen decreases in the rates of AIDS and mortality. This is crude mortality over time. On the next slide, we have age-adjusted mortality. And so the yellow line is age-adjusted mortality rates among HIV-infected women over the course of 20 years. The green line on the bottom is the average mortality, average age-adjusted mortality rate over time for the HIV uninfected women. And so this is a good news slide showing that the rate of mortality for the infected women has come all the way down to meet that of the uninfected women. So this is not women in the US, this is women in the WIHS. So although they're right here at the same point as each other, how are we doing with regard to what's expected? Not quite as well as we could be. So these are from 2010, the age-adjusted mortality rates for the US population overall, specifically for women and more specifically for Black women, are quite a bit lower. So we still have work to do. The WIHS has made many contributions to science over the years, not just those that I've shown you, and I couldn't possibly, especially the sign that just went up telling me I have 5 minutes left, I couldn't possibly go into detail on all of the over 650 publications that we've put out. Of course, they're all listed on our website here, so if you want to read 653 papers, I welcome you to do so. I just want to go, just hit a few highlights for you, just indicating that we've made many contributions over the years, from the prognostic importance of changes in CD4 and viral load after initiation of therapy, to risk of AIDS and death following therapy initiation, characterizing those women who are not on therapy, and again, trying to contribute to this idea of getting women into care, looking at anthropometric changes, atherosclerosis, of course, HPV and cervical cancer, among many, many others. So in the few minutes that I do have left, I thought that I would speak with you and share with you some stories from a little lunch date that I had about 5 days ago. I was asked to come and talk to you about what it's like to have HIV among women in the US today, and I thought I could tell you that with the data that I showed you, but who better to tell you that than women themselves? So I held a focus group with 10 of our participants last Wednesday. You can see some descriptive data just to give you an idea of who I spoke with. 9 were HIV infected, 7 were African American, the other 3 Latina. 5 of the women were in their 40s, the youngest was 42, 4 in their 50s, and the oldest was 62. The woman who had been infected the longest was infected in 1981, and the most recently infected was in 2011. I asked them 3 questions. What are the biggest challenges facing HIV-infected women in the US today? I told them about the symposium and asked, what would you like the Hopkins HIV researchers to know? And what questions would you like us to be pursuing in our research? So here's what they had to say. They talked about their symptoms. They mentioned neurologic symptoms. They mentioned cognitive symptoms. They mentioned pain. They mentioned menopausal symptoms. And they want to know, are they, the symptoms, because of my HIV, my medications? Is it regular aging, inactivity, genetics, something else? They want to know what's going on with their bodies. They said a lot more than just that, but I'm afraid of the timer. They're concerned about the future, saying, I just want to grow old gracefully and not be hurting every day. The woman who mentioned bone pain to me said that she has not had one single pain-free day for the past 2 years, not one. I said, pain meds don't work? She said, I can't take narcotic pain meds, I'm in recovery. So what does she do? She lives with pain. They're concerned about family, saying, when I get older, I don't want to be a burden on my kids. These women have advanced directives, they have wills, they have power of attorney all set up. 2 women told me I had the box sent to me. That took me a minute. The urn for their cremation. They have all of their plans in place. These are not elderly women thinking about death. These are women in their 40s and 50s and living with HIV. Stigma. We women don't take care of ourselves. When society is telling us we've done something wrong, that only gets worse. Disclosure. Some of these women are married or in long-standing relationships. The youngest one, the 42-year-old, is out there dating, and she said she's decided when she meets a man, she tells him right off the bat because, as she said, I don't want my HIV status to be something that someone can hang over my head. The last one I'll leave you with is legacy. They haven't forgotten the WIHS participants who have died, saying specifically, and I quote, we haven't forgotten the women who came before us and have passed, but how can we honor them and still maintain confidentiality? One woman spoke of her very good friend who was also a WIHS participant and has died. She said, I wanted to put a plaque in the clinic waiting room or something with her name and her photo, but I don't think I can do that. And the last thought I'll leave you with, if you take away nothing else from the last 15 or 20 minutes, this was the most powerful thing that I thought was said in that hour that I spent with these women, and I hope you'll remember this too. In direct response to my question about what these women would like for us, for the Hopkins HIV researchers to know, I hope our names will go on until they find a cure. Don't forget us. That way our names can live on and our children can benefit from all that we have done. Don't forget us. Thank you. Of course.
So, I think it's really compelling to hear the qualitative and the quantitative together here.
We were talking about the WIHS study. Is that completely enrolled now? There will never be any more enrollment, or what's the future for that?
Never say never. So right now we're only enrolling at our new sites in the southern US. And that enrollment is almost complete. So our current funding goes through 2017. Am I hoping we'll be funded for an additional 5 years after that? Yes. Am I optimistic about enrolling additional women? Remains to be seen.
Have you considered specifically dealing with a lot of older women? I noticed you only had one that was 62.
Well, that was in the focus group.
In the focus group,
Right.
but I'm saying, okay, I'm positive I'm 68, and there are a lot of women closer to my age now, but rarely do we find a lot of statistics or information
Yeah.
on how we're doing.
Right. So we do have the ability to look at that. 10% of our cohort is over the age of 60, and 25% is over the age of 55. So while we started as a younger cohort 20 years ago, many of our women have aged with us, and so we now have the ability to look at issues specifically among older women. You know, I think that's a lot of where the field of HIV has been going, with focus on aging and the fact that because therapies are so effective, women are living longer with HIV, and so we're able to branch out and look at all of the diseases previously associated with aging that now HIV infected women are looking at. And so we can certainly look specifically among older women as well as comparing older and younger women. Thank you for your question.
So the WIHS has always had a seronegative component as well.
Yes, we're about 3 to 1 positive to negative. Yeah.
So do you have data or questions on PrEP awareness in that group?
We do. Very, very few of our women have taken PrEP. I think it's 8 women. Very few of almost 1,000 negatives ever enrolled. They're, of course, not all, currently still active. Yeah. It's very low.
Do they have interest or awareness of PrEP, do you know?
We're still looking at those data, but yeah, we do ask.
suggesting in terms of research questions? I should be using this. What else were they asking in terms of research questions that they wanted sort of the WIHS to pursue?
Yeah, so, most of it focused on their symptoms. So, I mean, they spoke about their symptoms with medical authority like I just did not expect. They mentioned peripheral neuropathy. They mentioned cognitive deficit, short-term memory loss. I'm having my own short-term memory loss right now. All kinds of things. And a lot of it was menopausal symptoms, really just looking at issues that they're experiencing as they start the aging process and wanting to know, am I aging differently because I'm HIV infected, or is this what everyone out there is going through?
Thank you.
Thank you very much.
So much. Thank you so much. Wonderful, thank you. So we're going to sort of branch out and really take a look at the global epidemiology. And our next speaker is Dr. Deanna Kerrigan, an associate professor here at the School of Public Health, and has really a long history doing community mobilization and engagement with very, very high-risk women. I think we're going to hear a little bit about that, as well as very recently directing a large-scale USAID project, Research to Prevention. So thank you for being here.
Okay, thank you very much for the invitation to present a brief update on the global situation of women and HIV. I'm going to review the global burden of HIV among women and look at trends and progress to date, as well as focus in on some groups at heightened risk for infection, and also examine some of the key elements of the HIV response for women to date and look at some of the gaps and try and highlight some of the ongoing research and future research that may help us attend to some of these gaps. So we're now 30 years into the HIV epidemic globally. 78 million people have been affected with HIV during that time span, and 39 million people have died of AIDS-related illnesses. Currently, there are 35 million people living with HIV globally, 32 million are adults, and 3.2 million are children. Of these, 17.6 million are women and girls. That's over half the global burden of HIV. Additionally, HIV is the leading cause of death among women of reproductive age 15 to 49 years. If we look at the distribution of HIV across regions geographically, we see, of course, that the majority of the people living with HIV globally reside in sub-Saharan Africa, or 71%. In Africa, over half, or 58%, of people living with HIV are women. And this is different from other regions of the world, 50% in the Caribbean, but as we just heard from Elizabeth in terms of the United States, and that goes for North America and Western Europe as a whole, it's approximately 25%. So it really does vary per region in terms of the percent of women living with HIV. If we look big picture at some of our trends and progress to date, we see that while incidence has been declining steadily since 2001, 38% since that time, in 2013 alone, there was still 2.1 million new incident HIV infections. However, these declines are much slower among young women. Additionally, AIDS mortality has been declining steadily. Since 2005, we see a 35% decline in AIDS mortality globally, but again, still 1.5 million deaths related to AIDS in 2013. And while mortality has been declining steadily among women globally, it is not declining in the 10 to 19-year-old age bracket. So again, young women, adolescent women, a cause for great concern here, both in terms of prevention, treatment, and care. Looking a little more closely at the situation among young women and girls, we see in 2013 that more than 60% of all new HIV infections that were occurring in youth occurred in young women. In terms of adolescent girls, this translates into 380,000 new infections in 2013, and AIDS is now the second leading cause of death among adolescents globally. Looking at sub-Saharan Africa more specifically, we see that young women are twice as likely as young men in the 15 to 24 age bracket to be infected with HIV. And young women represent 25% of all new infections in sub-Saharan Africa. Additionally, girls, adolescent girls, represent 80% of incident HIV infections in countries hardest hit by the epidemic, like South Africa. And that translates, for example, in 2013 into 860 girls as compared to 170 boys being infected per week in South Africa. This just shows you visually that unequal distribution of disease of HIV in the 15 to 24 age bracket, comparing young women to young men of that age. And what you see is that young women are becoming infected 5 to 7 years earlier than their male peers. And this is most likely due to the fact that they're having sex with older men that have a higher prevalence of disease. I want to highlight a couple of key populations of women that deserve additional attention given their heightened risk for infection. Colleagues in the room, such as Tonya Potit, Steph Baral, and others, conducted a recent systematic review and meta-analysis of transgender women and found that they had a 49 times increased odds of being HIV infected compared to adults overall. Tremendously different increased odds. Among female sex workers, work that we conducted in a recent systematic review there showed us that female sex workers compared to adult women of reproductive age overall had a 14 times increased odds of living with HIV. What these groups hold in common, along with the other key populations such as female drug users, is experiences of risk related to criminalization, stigma, discrimination, and violence. Here you can just see visually the distribution of HIV prevalence among female sex workers per geographic region. And again, you see that the prevalence among sex workers is up to 32% in sub-Saharan Africa, looking at the pooled prevalence for the region as a whole. This drops down for the other regions, varying between generally 3 and 5% in the other regions. However, if you compare that to the overall general population prevalence, it's generally somewhere between 5 to 10 times greater than that general population prevalence. In the case of Africa, it's still 12 times greater than the average prevalence of women of reproductive age. Now, the reasons for the experience of increased risk among women have multiple components: biological, behavioral, and structural. We know that biologically, women are twice as likely to become infected with HIV through unprotected heterosexual sex with an infected partner. And of course, as has been spoken of earlier, heterosexual sex is the main mode of transmission among women globally. And young women and girls are particularly biologically vulnerable due to perhaps the immature cervix, as well as vaginal trauma resulting from non-consensual sex. The lower social status of women and girls is reflected in a number of sociostructural determinants of their increased risk. These include inequitable gender norms, gender-based violence, discriminatory laws and policies, and unequal opportunity structures, including education and jobs and livelihoods as a whole. These sociostructural determinants, of course, translate into increased behavioral risk for women. In turn, the literature indicates and calls for tailored, comprehensive combination prevention for women that tackle each of these domains: the biomedical, the behavioral, and the structural. However, to date, very little has been taken to scale globally. I'm going to start by just looking first at one of the biomedical components of combination prevention that's gotten a lot of attention recently, and that's PrEP, pre-exposure prophylaxis. So here you see a graph that looks at the efficacy of PrEP per the level of adherence to PrEP in multiple clinical trials that have been conducted over the years. Of course, as Chris was indicating, we had some disappointments, particularly in the area of topical microbicides for women, early on, as well as in the more recent FACS trial. However, what we do see from some of the other study that did include women is that, and this is in reference to oral PrEP, that if we can get adherence to a high level, we do see efficacy among women as well. There are still some concerns around the issue of biologic fragility to adherence among women, but this leads us in the direction to think that if we can support adherence among women, we can see effective results for women in terms of PrEP. But the question remains, and we'll talk about this in a few moments, is are we giving them the right products? are topical microbicides the way, or is oral PrEP the way, or other mechanisms and delivery modalities should they be considered? Looking for a moment at the issue of ART among women for the purposes of treatment and treatment as prevention, we see that globally, women generally have greater access to HIV testing and ART than men through antenatal care. And at this time, 67% of pregnant women in low and middle income countries are receiving ART for PMT-CT, which is great and has been a significant increase in coverage from 47% in 2010, except for there's still 3 out of every 10 women not receiving PMT-CT. Additionally, let me say that it's very difficult to get women data on women in treatment outside of the domain of women being pregnant or in ANC clinics. So there's a whole area of research there that I think we could do better at. Also, ANC screening often leaves out young women and girls, limiting HIV diagnosis and linkage to care for that highly vulnerable population. What we also know from the literature is that key populations of women, such as female sex workers, have lower access to ART. A number of studies have documented significantly lower levels of ART adherence among women compared to men. So while in the case of engagement in care globally, we see that women are doing better than men, we do still see that there are issues with adherence to ART once they get on medicine. We see specifically lower levels of adherence among vulnerable groups like female sex workers, and a recent systematic review among this population found that approximately 50% of female sex workers were virally suppressed, which is a particular concern for both their own individual health as well as population-level transmission dynamics, given the large, generally extensive networks of those women. So as I was alluding to a bit earlier, I think some of the questions that are going on right now in the field is how do we expand women's options, particularly around ART prevention and treatment modalities that might be more responsive to their realities and their lives. There are 2 ongoing randomized controlled trials of vaginal microbicide rings that everybody is very interested to see the results of, the RING study and the ASPIRE study, to see if that modality, where we only have to change the ring once a month, if that, given the multiple roles and responsibilities of women as mothers, as wives, as caretakers of other people living with HIV, if that may be more effective for them. Additionally, there are phase 2 trials of long-acting injectable methods of both PrEP and ART, where you might have to get an injection for treatment or for PrEP only once every few months, which may again be more conducive to women's lives. And women in many settings are used to injectables for the purposes of contraception and other issues. I'm going to switch from the biomedical here to the structural and talk a bit, just briefly, because I know this will be attended to later, the issue of intimate partner violence as well as some of the economic vulnerabilities of women. So a recent WHO systematic review found that women who had experienced IPV, intimate partner violence, either sexual or physical, were 1.5 times more likely to acquire HIV. So significantly higher risk among those women, in addition to a myriad of other negative health consequences to IPV. Exciting news has recently come out from the Hopkins Rakai team, led by Jennifer Wagman. The SHARE evaluation, the Safe Homes and Respect for Everyone intervention, is the first intervention that has actually demonstrated an effect. This is an intervention, a multi-level intervention, community-based, that was intervening on IPV within the context of a larger comprehensive HIV prevention package. It's the first one to show a significant impact on both IPV and HIV incidence, which is really game-changing for the field. Some of the previous studies, the IMAGE study, the SASA study, had shown positive trends in terms of IPV and HIV risk behaviors, but never an impact on incidence. So this really leads us in the direction of thinking seriously about how do we at scale integrate GBV prevention into combination prevention for women in sub-Saharan Africa. Another type of structural intervention that has garnered a lot of attention in recent years is the issue of cash transfer interventions to attend to the economic vulnerability of women, particularly young women. And we talked about the idea that younger women may be more vulnerable to infection due to having sex with older men, and this may be out of economic need, desire for social status, and other motivations. A study in Malawi and Zambia found that among 1,300 women and girls who were provided with either a conditioned cash transfer on school attendance or an unconditional cash transfer, that those women in both of those arms compared to a control had a 60% lower HIV prevalence, 76% lower HSV2, 35% lower pregnancy rate. And not only did they have less sexual partners, but they had less older sexual partners, which gets at that disparity in that 15 to 24 age bracket. And the benefits were consistent across both arms. As a result of that, there are now several ongoing studies in South Africa with incidence as an outcome to see if these positive trends that we saw in Malawi may transfer into significant changes in incidence among young women in the region, CAPRISA and HPTN studies. And we are, of course, very excited about those potential results. I also just want to talk a little bit about addressing the needs of key populations like female sex workers, and in particular, addressing the structural factors of their HIV risk. Some of the recent work that's been conducted, particularly some mathematical modeling that was conducted, suggests that tackling these structural determinants can lead to very significant changes in incidence among sex workers. For example, the elimination of sexual violence alone could avert 17 to 20% of new infections in Kenya and Canada over the next decade, and decriminalizing sex work could actually have the largest impact within both generalized and concentrated epidemics, averting 33 to 46% of new infections over the next decade. In terms of how we get there, community empowerment-based responses that actually mobilize communities within a human rights framework and integrate the biomedical, behavioral, and structural components have been associated with a 32% reduction in the odds of HIV. Again, the issue here now is to take these to scale. Some of our team are conducting a phase 2 trial of community empowerment-based combination prevention for female sex workers in Tanzania, and there are now other studies coming online, both domestically and globally, to look at these issues. What I want to leave you with after this brief review of the global situation of HIV in women is that women's vulnerability is, of course, multifaceted, biological, behavioral, and structural. And we absolutely need biomedical innovation in the realm of PrEP and treatment as prevention. But given the complexity of women's lives and social realities, the stigma, the discrimination, the violence, we need social change as well as biomedical interventions. We need those hand in hand. They can't be separate if we want to see sustainable, effective change for women. And ultimately, and interestingly, I really wanted to conclude on the same spirit that Elizabeth did, that we need to listen to women. We need to listen to what makes sense for them, what we need to be responsive to the complexity and diversity of their lives. And so high quality formative and operations research cannot be undervalued. Thank you.
Oh, thank you. Questions? That was so exciting.
Hi.
For the cash transfer program,
Sure.
can you explain a little bit of how that worked for the women and girls, and then
Sure.
other benefits might have been included in that?
Yeah, so it was a monthly cash transfer. Part of the money went to the parents and part of the money went to the girls. And some of the new studies that we see, they're kind of playing with the different modalities. Like, does it make more sense to have the money go to the girls versus just the parents? Does it make sense to have it conditioned on school attendance versus an unconditional cash transfer? The amount of money monthly was actually relatively low, it was up to $15 a month. But the interesting thing out of the Malawi study was that you saw the positive benefits of the cash transfer, whether it was conditioned or not. And you saw it across a range of outcomes. That study actually wasn't set up as an HIV prevention research study. They found that it had this impact on HIV prevalence along the way, but it was aimed at looking at a broader spectrum of outcomes. I think you could see that, you saw declines in pregnancy rates, HSV2, et cetera. So I think one of the interesting things about cash transfer is that it can have a multifaceted effect on women's lives, not just their HIV risk, but really their overall health and well-being and social development. Sure. Yeah.
You talked about how there hasn't been a lot of scaling up of some of the more tailored interventions. Could you talk about maybe some of the challenges of scaling up interventions that are particularly targeted at specific populations or
Sure.
And can you restate the question for
Should I speak into the microphone? Sorry.
You can do either, but just to restate it so our
Right.
webcast.
So the question, as I understand it, was about some of the barriers, about scaling up some of the tailored and targeted combination prevention packages specifically for key populations. So I can speak, most readily to the issue of female sex workers, which is a topic that I've worked on for many years. And we actually just did a recent review where we looked specifically at those barriers, like what is getting in the way. And how do we, generate and garner investment and resources in this area when we know epidemiologically that the heightened risk is there. But there are profound ideological barriers that are getting in the way. There is the conflation of trafficking and sex work. There is the lack of understanding that sex work is work. There is the fact that it is criminalized in most countries in the world, and the high levels of stigma, discrimination, and violence that sex workers face. So really providing investment not only in efforts that tackle the HIV risk of sex workers, but actually provide money for sex worker communities to mobilize themselves to address those barriers would be, in my opinion, a highly effective investment. Okay.
I'll ask you as well. So I'm curious, just the levels, it's disappointing to see such low levels of adherence, right, for ART. And I wonder, and I'm not up on this enough, but maybe where are we seeing impact in terms of community mobilization or texting? How can we get to a higher level of adherence, especially for our most vulnerable groups?
Yeah, so there's a number of different interventions that are being tried right now. I mean, ranging from individual counseling to mHealth. You talked about, texting and messaging, group support, as well as buddy systems and peer support around adherence. But there's also, I think it's an HPTN study on financial incentives, cash transfer incentives to try and promote adherence as well. So we see, there's a whole range of possibilities. And I think what's important is to be working in parallel to promote adherence to the current modalities of ART that we have, at the same time thinking out of the box about other potential modalities like long-acting injectables, for example, that might require less, they're less user-dependent, that require less adherence on a day-to-day basis. Okay, thanks.
Great. Well, I'm just so excited about really this conversation about bridging the behavioral and the biomedical, because I think we're hearing, and this is perhaps especially true for women given their complex lives and realities, that we need to be thinking at all levels about how we can really make use of these therapies that are coming out, whether it's ART, and now increasingly these very issues we're going to see sort of play out in terms of PrEP. So I think this is really pivotal that we're bridging the biomedical and the behavioral and the structural here in this room, but also really for the future of this field. And so adding another sort of layer into the mix next is really getting at this intersection of HIV risk, infection trajectories, and how does this interplay with reproductive health? So, we hear a lot in women's health, historically looking at women as sort of vessels for reproduction and so forth, and you'll see historically a lot of work on women's health that was really sort of probably at times overly focused on reproductive health, right? And here there's a real need and a real urgency, I think, into bringing HIV and reproductive health together to look at some of the shared risk factors, whether the behavioral, condom non-use, looking at some of the trade-offs in contraception and HIV protection that we see for women, trying to understand really how all of those things come together, both for prevention and for women clinically. And so I'm really so delighted that we have Dr. Janelle Coleman-Fennell here with us. She's an assistant professor over in the School of Medicine in the Department of Obstetrics and Gynecology, has come to us from Penn and also with some real hands-on experience on the ground in Kenya, and is really going to give us a true overview of all of this, so thanks.
So good morning. First, I would like to thank the organizers for allowing me to talk. So I'm going to have a different perspective. So I'm a physician scientist across the street at the School of Medicine, and a lot of what I'm going to talk about will deal with some of the sort of biological issues that pertain to women. So this is going to be sort of a whirlwind sort of tour. I'm going to talk about lots of sort of topics that are sort of up and coming in terms of research, but also some clinical dilemmas that mostly we have here domestically. So I'll talk about some issues that pertain to sort of the international setting, but a lot of this is sort of driven by what we're seeing here in Baltimore. So just to put us all on the same page, I wish I did have a pointer. So there are some differences between men and women in terms of HIV acquisition. So one of the biggest things, besides sort of behavioral issues that may be different, but there are some biological and anatomical reasons why women are more susceptible to acquiring HIV infection. So for one, we have, here's the vagina, the lower genital tract, and then you have the uterus and the fallopian tubes, which are considered the upper genital tract. And we know that there's just greater surface area. So if you have ejaculate that has infectious particles, there's just more area for it to contact, for it to cross the barrier. And also, it takes days for ejaculate to actually leave the genital tract, so you have a longer time of exposure of potentially infectious material inside the vagina. There are other sort of comorbidities that increase a woman's susceptibility to acquiring HIV, and one would be inflammation in the genital tract. And this can be from sexually transmitted infections, but you also have this when you get to sort of the menopausal area where women tend to have decreased hormones and possibly inflammation in the vagina. That deals with hormonal status, which I'll talk about that and some of the controversies surrounding hormones and its impact on HIV susceptibility. And also altered vaginal flora. I think there's a abstract later on to talk about the impact of bacterial vaginosis on cervical vaginal mucus and its role in HIV acquisition. So this topic of reproductive aging is unique, and it's something that lots of us are interested in. So as an OB-GYN, you take care of women who are maybe just entering puberty all throughout their entire reproductive lifespan until menopause. And there's so many differences along the way, just in terms of anatomy, physiology, and the hormones that may be present. So when you have the adolescents, as was already alluded to, with adolescents with their cervix, just structurally, there may be reasons why they're more susceptible to acquiring infections. And then you get to the extreme with menopausal women, where with the lack of hormones can cause the barriers to be very thin and friable and susceptible to trauma. So I like this cartoon basically because there's a lot, in terms of HIV acquisition, we still don't know exactly where in the genital tract HIV crosses a barrier. But this is a cartoon by Ashley House's group, which is really neat because it's pretty basic. And here, up here would be the vagina, and this is sort of the barrier. So HIV has to cross the barrier. We're not going to go into like how it does so, but if HIV crosses the barrier, whether or not it's the vagina versus the endocervical portion of the upper genital tract, we know we have exposure to HIV at day 0. And we know just through macaque data that up to 2 days, HIV, if it crosses the barrier, that if it comes in contact with cells that have been primed and ready for infection, such as when you have inflammation from a sexually transmitted infection, it can recruit these HIV target cells. We know that once HIV crosses the barrier, it can infect these cells and you can have replication. And then the virus spreads to the lymph nodes, and by 72 hours, it is believed that it's already systemically spread. So this is a sort of 72-hour cutoff that we use for post-exposure prophylaxis. So there's so many HIV biomedical interventions that can reduce a person's risk of acquiring HIV infection. And I'm not going to talk about many of these at all. We're going to have a really nice talk by Dr. Hoover on pre-exposure prophylaxis, or PrEP, treatment as prevention. I am going to touch on that because that's one of the most important interventions that we use as OB-GYNs to help decrease HIV acquisition. You have PEP, which I mentioned, PMTCT, clean injecting equipment, and treating sexually transmitted infections. So here was a nice review article that was published in the New England Journal of Medicine, and basically the purpose of this slide is just to point out the HPTN 052 study, which was pivotal in terms of decreasing HIV acquisition amongst an HIV negative partner if they're in a serodiscordant relationship. And then followed by that, you have other studies that list sort of the PrEP studies and medical male circumcision. But again, from sort of the standpoint as a clinician, we do use antiretroviral therapy-based methods to prevent HIV acquisition or transmission in so many different areas. So moving from sort of HIV prevention techniques to therapies to the headlines that were out in 2011. So this was the headlines, I think this was actually from Nairobi, that contraceptives double HIV risk. So this was a controversy that had been going on since the 90s in terms of HIV acquisition and perhaps hormonal contraceptive may increase that risk. But in 2011, with one study, the media took hold of it and it was published widely about perhaps there is this link. So since that time, there have been so many other studies looking at whether or not hormonal contraceptives, in particular Depo-Provera, which is the injectable contraceptive, actually increases HIV risk. So I can say there have been several meta-analyses, and even one here by Chelsea Polis, if you guys know her, she did one. But looking at this whole debate about whether or not hormonal contraception may increase HIV acquisition. And recently, I just actually selected, this was a meta-analysis published earlier this year by Nancy Padian's group. And basically, they took 12 observational studies, and 10 out of those 12 showed an increased risk of HIV acquisition with use of Depo-Provera, which is the injectable contraceptive method. They also looked at women as a whole, and then they took out women who were considered high risk. So they removed women who were commercial sex workers, as well as those who might have been in a serodiscordant relationship, and there still was an increased risk of HIV acquisition in those women who use Depo-Provera. They did not find an increased risk in women who use birth control pills or another injectable contraceptive called NET-N. So overall, this debate is still ongoing. WHO had a technical statement produced in 2012 pretty much to address this issue because this medication is used widely across the world. I can say mostly in sub-Saharan Africa, maybe the number one contraceptive agent that is used, and it's important in terms of decreasing, pregnancies, but it also is important for decreasing maternal mortality and infant mortality. So WHO's technical statement basically stated with all the data that's out there, these are observational studies. Some were designed to look at this specifically, but most were secondary data analyses, and that the data were inconclusive. So pretty much we cannot withdraw this from the market, still continue to use it because without it and not replacing it, many women may actually die. They subsequently, in 2014, added on some guidance for providers because it was sort of like this technical statement was out there, and as a provider, I still give this medication out to my patients a lot, certain populations more so than others, and so it was thought that what do we tell our patients, knowing that we have this sort of controversy that's raging, and the WHO sort of guidance basically stated that you should have a discussion with your patients, tell them about all the data. It's inconclusive, it's not sort of rigorous studies out there, and to recommend that they use condoms because this medication does not protect against infection at all. So now I'm going to shift to HIV serodiscordant couples because this is a very hot topic, both domestically as well as internationally. So we know in the US, we have very little data on exactly who or how many serodiscordant couples we do have. There was one small study that looked at HIV positive men and women that were engaged in care, and they asked them how many knew their partner's status. 20% didn't know, and 50% were in a serodiscordant relationship. When we look at sort of heterosexual serodiscordant couples, we know we have some data from sub-Saharan Africa just coming out of the antenatal clinics that like about 20% or less of their couples are serodiscordant with equal mix of male or female being a positive partner. Here in the US, the CDC tried to get at sort of how many couples, heterosexual couples are there. And a few years ago, there was an estimate that there was perhaps 140,000 serodiscordant couples, half of whom may wish to conceive a child. So this brings me to a topic that WHO has convened sessions on. Here in the US, we have multiple sort of meetings about conception for serodiscordant couples, and how do we do this? How do we help them get pregnant safely? So again, like I mentioned, two of the key interventions that we use would be sort of antiretroviral therapy for the index partner who's infected. So that's the HPT and 052. So if there's nothing else that we do, if you don't have access, if you could just select sort of one intervention, that's what it would be. The other is PrEP for the HIV negative partner, and I have sort of a question mark because that's sort of a personal discussion that I have with patients about whether or not she would like to take PrEP in addition to her partner being on therapy. We actually have a study going on now here in the US with 4 different sites on PrEPception, when you have the male who's positive and the female who's negative, and the woman wants to take PrEP, and pretty much it's an observational study where we just following them through time just to see, you know, if she's adherent to her medication, how difficult is it for her to remember to take her PrEP. And the other thing that we do is screen and treat for sexually transmitted infections. So for HIV-positive women who would like to get pregnant in a serodiscordant relationship, as long as there's no fertility issues, it's pretty simple. Pretty much what I do is recommend just timed condomless sex, just timing sex during the most fertile time of the month, which I can say it sounds easier, but it's really hard to sort of pinpoint that fertile window. Or they can undergo artificial insemination at home, meaning that they can go ahead and have intercourse with a condom and then just sort of withdraw the ejaculate with a syringe and deposit it into the vagina. However, when you talk about an HIV-positive man, this is when it becomes very tricky. So here in the US, we have access, well, we have the availability, put it that way, of so many advanced sort of reproductive technological advances. However, I can say my patients typically do not have access to those services. And this is the same for patients in developing countries. So when you have this HIV-positive man and a negative woman, and this couple would like to conceive a child, the issues are sort of like, what do we do? How do we help them conceive a child safely? And going through the motions, and you have to figure out sort of what context you're in and what services you have available. So I can say here, luckily we do have access to at least checking out the male's semen, because we know that for HIV-positive males, either HIV itself, but mostly it looks like antiretroviral therapy may sort of have a role in creating sort of this abnormal semen environment, so that their semen parameters may be abnormal. And I didn't even see that sign. Okay. And well, let me go. So, so with the semen parameters, so here I can say we do get a semen analysis, but again, it is placing the positive partner on therapy, having them suppressed for at least 6 months, and then having them go ahead and time intercourse. So now I'm going to switch gears to pregnant women, and there are many different sort of issues with HIV and pregnant women. So the first is that we recommend preconception counseling and care. So our goal is to have all HIV positive men and women to have a discussion with their provider about their fertility intentions and goals. So before they even embark on it, just to have a discussion for many different reasons. One of the biggest is that we looked at our data here, and lots of HIV positive women are delaying childbearing, and I'm not sure that is actually sort of their choice. It might have just been that perhaps they didn't think that, you know, they didn't want to talk to their provider about it. Maybe they're having difficulty getting pregnant. But I know for our group, most of these women were over the age of 35, which just in general, having a child over the age of 35 is considered advanced maternal risk. And then we also know about maternal child transmission, and one of the goals of preconception counseling and care, and reducing the risk of transmission to the infected partner, which is where just HEART comes into play. And if she doesn't want to get pregnant, then talking about sort of different contraceptive options. So for the elimination of maternal child transmission of HIV, this is a global sort of goal that we have here as well as abroad. And one of the key things is identifying women who are HIV positive. So I know here there's several initiatives beyond just testing when a woman first comes in for her first prenatal visits, to repeat it in a 3rd trimester, regardless of the sort of patient's or the provider's perception of the patient's risk. It's just to kind of continue this HIV testing in pregnancy so that we can detect women who may seroconvert. And then it's placing them on medications. And some of the sort of issues that we have here as well as abroad is adherence to medication still. So we have access to services here, we have social work, we have wraparound services, but even here we still have about like 25%, if you ask 20 to 25%, lots of centers who still do not have their whose pregnant women still have a detectable viral load before they deliver. So that's something that we're still working on in terms of improving that. And then ART safety in pregnancy is still a big deal. So when I hear about these long-acting injectables, that's the first thing I think about. It's like, what happens if she gets pregnant and this is a medication that perhaps we don't have any information on? So that's sort of challenging with all the new medications that are coming out. What do we do when they get pregnant? It makes sort of, as the provider, when she comes in, do we switch? Do we keep her on it? Do we just sort of continue on? And then postpartum linkage and retention and care, same deal. This is happening sort of abroad as well as domestically. Women may come in for prenatal care, they may take their heart, but then postpartum, there's this precipitous drop, and they may not show back up into the system and take their medication. So that's a sort of active area that people are looking into. And then I'm just going to put this provocative sort of this thought is sort of breastfeeding. There's this breastfeeding debate that's happening now in the U.S., which I find to be very interesting, and whether or not to have conversations with women who are HIV positive, mostly immigrants who may be motivated, whether or not going through this sort of shared decision-making process of talking about breastfeeding, even if they have sort of other options in terms of formula. So we all know that contraception is good. It can avert about 44% of maternal death. So when I was talking about withdrawing Depo-Provera, I don't think it'll happen, just because we know that if you withdraw Depo-Provera and not replace it with another agent, for every HIV case you avert, you will have like 9 maternal deaths. So it's one of these things that we know it's very important. We have to do more research on it to try to figure out something that's safer or increase the method mix. Here in the U.S., this is one part of the WIHS study that just blows my mind, is that we still have HIV-positive women here in the U.S. who do not use what we consider an effective form of birth control. So the WIHS data showed that about 73%, at least women in their population, were using condoms as their predominant mode of contraception. And we know that with condom use that patients are going to get pregnant. Here is something that I show my patients just in terms of, and you can get this on the WHO, really simple in terms of like what is the least effective to the most effective contraceptive options for HIV positive women. And you can see here spermicides, which are not sort of recommended, especially for HIV negative women, or naloxone 9 is not recommended, up into the most effective ones like the implants, the IUDs. So this is pretty much where we are with most of our patients, is trying to encourage something that's more effective compared to the ones that we know that they may forget to take. Sort of some of the last 2 slides. One is cervical cancer prevention. If you guys realize in the media, there's a lot of excitement about screening for cervical cancer in HIV negative population, whether or not you do pap smears, every 5 years, every 3 years, primary HPV DNA screening, very exciting, but none of that pertains to HIV positive women. So this is still an area where we feel when you're dealing with HIV positive women is sort of what is the best way, the safest way to screen this population, given that they are at higher risk for cervical disease as well as cervical cancer. The last thing is that HPV vaccination in this group. HPV vaccination in the U.S. alone has been dismal. It's less than like 35% of all eligible girls are vaccinated. But in the HIV positive women's group, I see it all the time. It's like women who are aging with HPV disease. It just wreaks havoc in the entire genital tract. And it's one of these things that we're trying to figure out, how can we increase the uptake of HPV vaccination, especially in this population that could benefit from it most. I want to touch on HIV and aging and menopause because it is one of these things that is not well studied. There's lots of conflicting data about whether or not HIV positive women enter menopause earlier than other women. The data has many flaws, and I think the biggest is the definition of menopause, and so that's why we don't have a great answer. And then some of the medications that HIV positive women may take may also lead to sort of suppression of the hormones, so she may appear to be in menopause, but she might not be. The other thing is symptom management is really tough in this population. I have patients that I have on sort of the highest doses of some hormone replacement therapy, but they're still having symptoms. So I feel like just leave this sort of thought in your mind. I had this one patient who came in, I had her on mega doses of hormone replacement therapy, and she told me her experience in church, when she's there in church and she's sweating profusely, and she said that she felt like a pig in church sweating or something like that. And she said that the sweat was coming down, she was embarrassed, and her wig was skewed. So when she got to stand up, she was just so like, oh my gosh, what am I going to do? Because it's pouring down sweat, and she's like, everyone's going to look at me and notice that I'm dying over here. And as a provider, I don't have a lot of data on like how to manage this. So this is something that, again, we need more research on HIV and aging and menopause. So we also know that bone health is worse. There's several studies that have shown that, as well as cardiovascular disease. So given that 25% of our HIV population here in the US, probably a bit more is menopausal, we definitely need to increase our efforts there. This is my last slide on sort of one of the major topics would be ethical issues. I had to touch on this because I think that Dr. Faden's phases study is just remarkable in terms of making sure that women are always part of the agenda. Women who may get pregnant should still be enrolled in clinical trials. Women who get pregnant during the clinical trial, what do you do with those women? And to start that dialogue and that discussion, because lots of the studies for HIV prevention, for like some of the microbicide studies and PrEP, once the women were pregnant, then they were no longer a part of the study. But then it's like, okay, so when you're dealing with pregnant women, we don't have a lot of data because they're not included in these clinical trials. And the other thing is that folks talk about the cure agenda, and it's just one of those things that women have to be a part of this conversation and enrolled in some of these clinical trials. I'm not going to go into this. This is just to sort of highlight that the NIH does have a website where they have sort of the women and girls HIV research priorities. So this is from 2015, and we're about to get together again to discuss sort of the priorities for 2015. So in the black are sort of the key areas and the sort of priorities. But it's interesting to hear the other speakers when they talk about involving, patients and participants in what they want. And I can say with this working group, there are no patients a part of this. So it is a bunch of researchers coming together saying what we think is the best for this research agenda for the NIH to broadcast out there. But it's definitely one of those things that hopefully at some point we'll have consumers or patients who are a part of this discussion. And then I'm just going to leave you guys with this. I saw this online, and I couldn't tell whether or not, I was kind of freaked out by it on one hand, but I find it to be very fascinating because it touches on so many different areas with HIV in women and sort of what that whole thing means. But thank you. Okay.
Thank you
Any
so much.
questions?
Thank you, Dr. Coleman, that was excellent.
Thank you.
I was happy to see expanding the research for HIV, especially in older women, and the part about the cardiovascular disease. I read recently an article from Boston about uncalcified plaque in HIV positive women and how there's a lack in research about what to do about that and the risk of that. So I was just wondering, as we move forward, of course, there's so many areas to cover, but cardiovascular is on the list for HIV in aging women.
Yes, cardiovascular is on the list. It's also sort of bone health, and we talk about sort of cognition as well. That's one area that I find to be fascinating because we know for HIV negative women, when they enter into menopause, there are cognitive issues and short-term memory losses. So it's one of those things that, yes, is it sort of worse? Is there something different that's happening with HIV positive women?
And one last statement about that, Jennifer Schrack, I think she's done some
think
work
I
on
know that.
frailty and bone disease, but also will this conference or symposium, have you been invited to be a part of the International Conference on Aging that happens here, right here in Maryland? This will be the 6th year. Charlie Flexner is the
Thanks for you can talk to me more about that. I can say, I'm actually going to plug one of my colleagues who's considered a menopausal expert. My research mostly deals with contraception, sort of the risk with HIV acquisition and contraception, as well as PrEP. But we do have someone here who's our menopause expert, and she was doing research in the Moore Clinic, our HIV clinic, just looking at sort of the first step was just trying to identify women who may have symptoms or who may be entering into menopause to kind of get a little deeper at this issue.
That would be great, because
Yeah.
I've attended each year, and they don't always have a lot on women
Yeah,
research, so not just
Interesting.
menopause, but that's for everyone.
yeah. Thank you for that. Yes.
Yeah, just wanted to ask a question about the HPV vaccine, and you talked a bit about the fact that, like, the uptake is low among folks under 26. So I'm just wondering, like, is there anything for the older population who may have acquired HIV before the vaccine was ever on the market? And if not,
What do they do?
like, what's the next step?
Yeah, so the question was whether or not the HPV vaccine is available for women over the age of 26, and if not, what can they do? So I can say that age cutoff is basically sort of the insurance cutoff in terms of whether or not the insurance company will cover it. So it's one of those things that if you're less than the age of 26, you're lucky you can get the HPV vaccine covered by your insurance. If not, you can still get the vaccine. You will just have to pay for it out of the pocket. I'm not sure if people know it. I mean, just given the fact that only like a third of the population is vaccinated, it's one of those things that, yeah, someone of older age can get it. One of the ACTG trials actually looked at HIV positive women and this HPV vaccine to see whether or not they would mount a response. And it was sort of a full age range, I think from 16 to 45. And the older women still mounted a response. And these were people who were sexually exposed to HPV. So it's one of those things that, yes, unfortunately, less than 26, they get it free. Over that, you would just have to pay for it out of pocket. The older vaccine, the Gardasil 4 that covers 4 subtypes, was about $300 total. This new one, this 9-valent one, I'm not sure how much it's going to cost, but it will probably be a lot more costly. Yes. Oh.
Do you see a potential role for co-formulated long-acting hormonal contraception injectables and long-acting nanosuspensions injectable antiretrovirals for PrEP? And what are the barriers to co-formulating them?
Ooh, so the question was about co-formulating sort of contraceptives as well as antiretroviral therapy, and I think it's a great idea. I actually think that's the way that's going to have to happen, because I can't imagine a woman, when we were talking about sort of issues with adherence now, and taking a pill or putting in the ring and then asking them to do both. So it would be great if you can just have one device. You have the ring that has like birth control, some sort of hormonal contraception, as well as antiretroviral therapy. So in terms of barriers, I think the whole thing would just be cost, like with anything else, but it is on everyone's mind to sort of co-formulate these together, because I think that's the best way to go. Yeah, and so, hi, Yvonne.
Question of the MPA for HIV positive women, because there's so many interactions with antiretroviral therapy and hormonal contraception that I know DMPA tends to be more preferred.
Yes.
But I've met providers who are really on the fence about the bone issues, and some will only prescribe it for 2 years, and some will say, oh my gosh, that's ridiculous. And I just wondered if there's any more clarified information as to how long women can stay on it, especially in the setting of HIV.
So the question was about Depo-Provera use among HIV-infected women and potential impact on bone. So I can say that there's no additional clarity on it. This was actually, I don't even know if I should mention this, but this was one of my CFAR sort of developmental ideas that I pitched, was looking at Depo-Provera, tenofovir, and HIV on bone health, because I do think I come in contact with a lot of women who've been on Depo-Provera for years. It may have been like 6, 7, 8. And when I see them, I freak out, because I'm like, oh my gosh, you've been on Depo-Provera for so long. And for those of you who don't know, Depo-Provera has a black box warning, FDA black box warning, talking about the impact on decreasing bone mineral density. So we don't have any sort of long-term data in terms of clinically whether or not that's going to pan out to increase fractures. But it is one of those things, if you have someone who is HIV positive on Depo-Provera for several years, so at that 2-year mark, I counsel patients about it. And most of them are surprised, because they're like, oh my gosh, I've never heard heard about this. And it's one of those things that I counsel and try to get them onto a different agent because I just don't feel comfortable, but we don't have any data on it yet. And I'm not sure that study will ever be done. I didn't get funded for it, but I think the biggest reason was trying to have the numbers, the sheer population. So it's something that probably couldn't be done in the States, but probably could be done in a different setting. Yes.
In terms of issues with adherence to PrEP among women, do we have a sense of how much is that is I'm forgetting to take my medication versus what does it say about me or what does it say to my partner if I'm taking this?
Yeah, so the question is, in terms of adherence to PrEP, do we have a better sense of why there's sort of such poor adherence to it? And I think there's probably a mixture of all of that you had mentioned. I can say that they had looked at, and maybe Dr. Hoover will go into sort of some of the issues, but one of the biggest things were whether or not women perceive themselves as being at risk for HIV infection, and perhaps they did not think that they were, so they weren't taking their medication. Here in the U.S., I'm not sure if folks have actually looked at that sort of question. Any other questions? Okay, thank you.
It's great to see all these questions and the discussion is sort of percolating along, which is really great. And I really do want to thank you, Janelle. I had asked her to really sort of cover, women in reproductive health, of course, across the life course with about, in about 15 minutes, which you did so beautifully. And I just to really flag, I think there are just so many rights issues as we're looking at this intersection in terms of reproductive health and HIV, respecting and protecting the right to contracept using the best available, safest means, and also the right to grow families and to become pregnant, again, with the best, most effective and safest means. So I think that's one of the real cruxes of all of this. So we're going to move into the structural determinants sort of portion of our agenda, and I'm going to invite Susan Sherman, a faculty member, professor in epidemiology and co-director of the Baltimore collaboratory of our CFAR, and a real key member of our planning committee for this group, is going to introduce our speaker. So thanks.
Good morning. It is my great pleasure to introduce Nabila El-Bassal, who's a professor at Columbia University, the School of Social Work, and the director of the Social Intervention Group, which since 1990, which is a long time ago, was looking at the well, no, it's amazing. I mean, her work is very seminal, looking at the intersection of HIV, gender-based violence, substance use, and she really has set a lot of the agenda, and I have to say she's a personal mentor of mine I'm very happy to start working with at this time. She also is the director of Columbia's Universal Global Health Research Center of Central Asia. She spends a lot of time in Kazakhstan, which is a team of faculty, scientists, researchers, and students in New York and Central Asia committed to advancing solutions to health and social issues in Central Asia through research, education, training, and policy and dissemination. Her work always has a great policy advocacy component, which I think is something we all appreciate. Through her work, she's tested and designed a number of multi-level HIV prevention, drug use intervention models for women, men, and couples in New York and throughout the world, including primary care settings, criminal justice settings. She's studied the intersection of HIV and violence against women and designed interventions, some of the first interventions that address these co-occurring epidemics, with significant contribution putting gender-based violence kind of on the map for HIV prevention. She has also mentored a number of students and researchers internationally and published extensively on HIV behavioral research, is funded by NIDA and NIMH, and we look forward to hearing her talk today. Thank you.
Thank you, Susan. Good morning. Let me find my presentation first. So I'm really delighted and honored to be here today, and I want to thank Michelle and Susan and all of you for inviting me to speak at this conference. Yes, I have been doing research since 1990, and I am a social scientist. I'm also a social worker. I teach at the School of Social Work, and I am delighted to say that all my research focuses on the voices of women. I care very much to bring the voices of the women when I do my research. I also focus on my research on women who use drugs, sex workers in the United States and other countries. But also I have been very committed to doing work with women in the criminal justice system. And I have to tell you, it's a forgotten population. And if you look at the literature on women in the criminal justice system and HIV, you don't see much, and no one wants to talk about it. And when you look at the science and you see why we don't study women in the criminal justice system and HIV prevention, the response in all the papers, oh, not many women are in the criminal justice system, we have small sample sizes, we don't need to study them. Clearly, we need to study men, but women are important in this case. And I want to share with you today a very complex issues around the intersection between drug use, HIV, violence, and criminal justice. And as you see in my title, it's HIV, gender-based violence, drug use among women affected by the criminal justice system, social determinant, and HIV prevention. I plan, in fact, my talk has two parts. The first part is I want to talk about the burden of HIV and criminal justice and gender-based violence, partner violence and gender-based violence, drug use. When I highlight the social determinants that I found in my research in the past 15, 20 years, and then I want to end my presentation by talking about HIV behavioral interventions for women in the criminal justice system. I hope I leave this presentation by giving you a sense of where we are in the science of HIV prevention in the criminal justice system with women. I think I have an easy really time now because my colleagues earlier talked a lot about the burden of HIV, so I don't want to focus much on the burden of HIV, but I want to focus a lot on the burden of incarceration among women. Briefly to say, according to UNAIDS, we know that 10 million people are imprisoned at any time in the world, and this report was published in 2012, and 30 million people are incarcerated every year. And in fact, in the same report, UNAIDS said that in the past 15 years, the prison population increased 30% globally. However, the world population increased 20%. And in the United States, we have the largest people in prison. As you see in this figure, it's about rates of incarceration. If you look at the first one, we have 716 per 100, rate of prison per 100,000. It's a huge, and we come before even Rwanda that incarcerates so many people, and Russia and Central Asia. We have a lot of people in prison. And a female, in general, globally account for 15 to 20% of total prison population. However, the rate of incarceration for women is higher than the rate of incarceration in men globally, and I'll show you in the United States. And why women are in prison? Because most of them, 40 to 60% of female prisons, are there because of drug-related offenses. So we can really separate drug use and imprisonment. Look at this figure. In the United States, we have more than a third of world female incarcerated population, more than a third we have in the United States. However, women in the United States account for only 5% of the world female population. So look at this figure also too. From 1980 to 2012, there is an increase of 800% of women in prison. In 1980, we had more than 13,000 women in prison, but in 2012, we had 113,000 women in prison. It's a huge number, and people saying we don't have enough. Look at this even recent figure in 2013. We have 200,000 women are in prison, and the women in 2013 account for 9% of the total prison population. It's a huge number. And then I try to compare with other countries where I do my work in Central Asia. We incarcerate more women than in Central Asia and in Russia and in China. We have more women, and here is the debate around why we don't need to include women in HIV prevention, although look at the statistics. And here I want to share with you this graph. It really tells you a story. If look at 1980 until now, there is increased rate of 3% of the women population in prison, 3%. Clearly, we incarcerate a lot of men, but the rate of incarceration among women is higher than the rate of men. For men, we see the incarceration rate is 1.8%, for women 3%. There is a population that we don't talk about it, and I'm very, very committed to women in alternative to incarceration programs, like women in probation, women in drug courts. There are 1 million women in these settings, and you'll see later in my talk, we don't know much about these women in terms of HIV prevention, in terms of violence against women. We don't access this population, and the 1 million women are in and out of the prison, and we don't do much for them. And as you know, black women consist of 13% of the female population in the United States, but they account for more than 50% of the women in prison. This is another way of looking at the severity of incarceration among women. If you look at the non-Hispanic white, they account for 47 per 100,000. For black women, 133 per 100,000, the rate of incarceration among non-Hispanic black women. Among Hispanic, the rate account for 77 per 100,000. There is a huge problem with racial disparity in terms of incarceration and recidivism. I want to tell you a story. I have been so interested in looking at the locations of where incarceration is taking place in many states, but also in New York City. And I have a friend who spent a lot of time looking at by zip code where incarceration occurred in different communities in New York City. And as you see in this map, it says men, but also women. Women are incarcerated from this neighborhood, Brooklyn and Harlem, and the poorest neighborhoods and areas in New York City. And later, I'll show you how this is mapped with not only poverty, but HIV. All the HIV cases occur in this neighborhood, all the incarceration occur in this neighborhood, and there is really match where we see the cases. It's no different than what you see in Baltimore, and this is a report, I'm sure all of you are familiar with this report, was published only a few months ago, showing that a third of Maryland residents in state prisons are from Baltimore City. You know this story, I don't need to tell you. But if you look at where they come from 5 neighborhoods, no different than what I have found in New York City. They're coming from the same neighborhood that affected by unemployment, by homelessness and other problems, by HIV. It's not different than New York City. I became very interested in the issue of women stops and search and incarceration, as well as sexual harassment and sexual abuse. I became interested in this issue only in 2011 when I saw this story in New York Times. And New York Times put out this story, and I tried to advocate to take the voices of the women at the next level, and it didn't go far. But here is the story. In New York Times story, it says that there were more than 46,000 women were stopped and searched, which account in 2011, in 1 year, stopped and searched and harassed sexually, which this number accounts for 7% of all the stop and frisk cases in New York City. Of course, when the story was out, they were saying, wow, 7% of the women, okay, 46,000, it's not a lot, why we need to focus on this issue. But here is the quote from a woman which made me really very committed to pursue this type of research and look at HIV. She says, a male officer should not have a right to touch me in any sort of manner, even if it's outside my clothing. She's right, we are girls, there are men, and they are cops. And she said, it feels like a way for them to exert power over you. But this story was out there, and no one really listened to this story. So I started really searching the evidence. I wanted to bring the voices of the women out. So I started with a student of mine to look at data that are available, and to look where are the women that are searched and stopped in New York City. And as you see, the red dots are the same as where I showed you when women were incarcerated too. And these dots showing that many women were stopped in 2012, similar to what happened in 2011. And I am now curious to look at the profile of these women. Who are these women? And one thing that I'm seeing, I haven't published it and I'm working on it, in many places where there are drug treatment programs, where women in their way to drug treatment and harm reduction programs, there are stopped there in their neighborhoods. I haven't published these findings. I'm looking at it closely, but it's really a serious issue. The women in their way to get treated, they are stopped and searched by the police. And here is what I have found so far in terms of the characteristics. Again, it's consistent with the story of New York Times in 2011. The women account for 7% of the cases that they stopped and searched. A huge number of men, as you see here. But then I looked at the racial ethnicity of the women. Mostly are black women, as you see here, around 52% of the women, and black Hispanic 5%, Hispanic 4%, and white 13%. It's a serious issue that we have not looked at when we talk about violence against women or we talk about gender-based violence. This issue has not been addressed in HIV prevention. I don't need to talk about HIV, how many women are HIV positive in the world. We heard from wonderful speakers earlier how many women are living with HIV. I want to skip this and talk about incarceration in prison. So what do we know about the rate of HIV in the prison? There are data around the globe and showing, I don't trust fully the data, but showing that around the 1.7% the HIV prevalence rate of incarceration in the total population in the United States. Here is some data. It's really hard to find data about women, but it says that in 2012, HIV prevalence in prison among women was estimated to 2%. But again, there's not much data. And if you notice in my slide, and I purposely put it here, there is a citation in 2004 about HIV prevalence among women and their community supervision. 2004, the prevalence rate was 17%. It's not really, it's old data, but it's huge. So what I'm trying to say is that the HIV prevalence is higher among women in alternative to incarceration programs. So I start really looking at these issues closely, and I have a number of studies funded by NIDA to look at HIV in criminal justice system in community supervision. So I conducted a study in 2004 was published among 306 women in a community supervision in New York City. What I found that the prevalence of HIV is 13%. And I also found that the rate of STIs is 30%. It's a huge. You'll hear me talking about this project more and more in this presentation because it's an intervention study. And this data is from the baseline. It's really huge. It's not different than what we were saying and we were finding in Africa. So I want to show you how HIV and incarceration are coming from the same neighborhood in New York City. Here the map that was conducted by my colleague from Columbia about admitting people in prison, and here another map that I accessed through the New York City Department of Health, and I don't see the difference. That's where we get the people to be for HIV. Moving to the third topic that I'm also committed to, and I have been doing a lot of work about gender-based violence and taking really a microscope and using both qualitative and quantitative work. As you remember, many of you in this room have contributed a lot to this area of HIV and violence, but the good news that was in 2006, what I was so excited to see that WHO has identified that IPV is one of the major risk factors for HIV. And since then, we see an escalation of the research and funding and publications around the connection between IPV and HIV. Now, what's happening with IPV in the prison? As you see here, that more than 50% of incarcerated women have reported ever experiencing severe physical abuse. That's according to the Bureau of Justice. It was published in 2009. And more than a third of incarcerated women have reported being raped, meaning forced sex with physical force at some point in their life, according to the report. But when you look at a partner abuse among women who use drugs, it increases closely to 90%. So women who in prison and have history of drug use are really heavily abused. So I want to start to talk about my own work and recent data. I've been published only in 2004. So I conducted a study. It's called Project Worth, Women on the Road to Recovery. with women in alternative to incarceration programs, mostly came from probation settings. And it's an intervention study, and you see me talking about IPV, but later I'll talk about the intervention itself and the outcomes of the intervention. So most of the women who we included, the 306, are African American women, not surprising. And I looked at the baseline about the prevalence rate of IPV. As you see here, 63% of the women experience sexual and physical violence in their lifetime, and 25% in the past year. Also, it was interesting to see about sex work, whether IPV increases if the women have history of sex trading. And as you see here, 41% of the women reported that they engage in sex trading. It's a population that we really need also to pay attention more to. And so I looked at the prevalence of IPV among women who traded sex for money or drugs, survival sex. As you see here, the prevalence of sexual IPV in the past year was 46%, and a severe sexual IPV rape, meaning, was 30%. It's a huge really problem. I have another study. It's called Women Initiating New Goals for Safety, that also we're in the process of publishing the findings. We included 190 women in an intervention study, so I'll talk about the baseline data here. As you see, mostly are African American women and Hispanic. We recruited them from probation sites, and we looked at, again, the prevalence of IPV. As you see here, the prevalence of IPV, disclosure of IPV, was 47%. So I also wanted to know whether or not we see a prevalence of IPV differs by whether the women engage in sex work and the women have sex with women in this sample. And as you see here, the prevalence of IPV, if the women have sex only with men, was 43%. But if the women engage in sex work, the prevalence of IPV increased to 50%. And if the women have sex with women, then the prevalence rate increased to close to 70%. So we can have a debate and discussion later about women who have sex with women, why there is increase in IPV. But I have to say that if you look at the science of HIV prevention intervention, we don't know much about women who have sex with women in the criminal justice system. We don't know much about, we don't provide any interventions. And I would really love to leave this presentation by maybe encourage you to be exploring this issue, because it's an important one. There is another issue that I want to talk about, is we don't talk about it much, is sexual abuse by law enforcement. It's a huge issue and leads to HIV risk behavior. I want to share with you a study that I really appreciate very much by Dr. Wolf, although it was published in 2007, but the story has not changed. She looked at violence against women in the prison by law enforcement, and she had in her sample 564 women, and what she found that the prevalence rate of IPV is 25%. But also what she looked at, women who have mental health problems, which is a huge number of women in the prison, and she realized that the partner abuse, the prevalence is higher among women with mental illnesses. So you see 27%. And she was interested to see with whom they were abused. As you see here, they mostly were abused by other inmates, but there 14% were abused by staff, law enforcement staff, and 15% by both law enforcement and staff. And then she was interested in to see whether there was racial differences, ethnic racial differences among women who were abused in the prison. And as you see here, she controlled for many issues. And at the end, in her analysis, she found out that African American women reported higher rate of sexual victimization in prison and mostly are abused by law enforcement. So abuse by law enforcement occurs in the community a lot, and this is in a study that was published in 2014 by Dr. Cutler in a study with 318 women in drug courts, and she found out that 25% of the women have history of police sexual misconduct in the community. And she was interested in looking at if they were abused, physically, raped. And as you see here, 31% of the women were raped by an officer. It's a huge problem. And not, of course, all use condoms. 51% did not use condoms. I have two studies in Kazakhstan and Kyrgyzstan where I did the same thing, and I looked at women if they were are abused by law enforcement, and I see the same story. In fact, I have to say that we know more about sexual harassment by law enforcement and sexual abuse by law enforcement in other countries, and we don't study these issues. If you look at the science and research on these issues, we don't know a lot. So I also encourage you to look at this issue. Violence, HIV, drug use are so interconnected, and they're really heavily affected by this many social determinants that are common. And this is a map that talks about how HIV and violence are connected. There are a number of people who have studied these issues and write a lot about it. But we know that how HIV is connected to IPV, it's by women having unprotected sex with HIV-infected partners. And as a result, they are infected with HIV and STI because unprotected sex. And when they have forced sex, they have, of course, vaginal laceration occur from forced sex and leads to unprotected to HIV and STI. But what's important for us to remember is the contacts that lead to all of this, and why it's important, because we need to address them in HIV intervention prevention strategies. We talked about how women are not able to negotiate sex, how women don't want to lose the relationship. They don't say no to condoms because they want to stay in the relationship. Some women, when they disclose HIV status to their partner, they increased risk of HIV. And also mental health issues that I earlier mentioned that increase the risk of women to have sex with infected partners because they cannot negotiate condoms. But also there are the macro social contacts that are very important. Incarceration is one of them, but unemployment, financial dependencies, homelessness, stigma, gender inequalities, lack of gender-specific services, and lack of policies to protect women. All are these issues that we need to consider in talking about HIV prevention interventions. They're not different by also looking at women who inject drugs. We know that women who inject drugs, there is a direct contact between sharing syringes or sharing needles that lead to HIV and STI, but also the context is similar to what I described earlier in terms of the macro social context, but also there are other issues on the relationship between the men and women. Women are first inject drugs by her male partner, women second inject by her male partner. Women tend to fear injecting themselves. They couldn't find the veins. They hide from the police to inject themselves, and it takes time for them because they're uncomfortable doing it. The women don't want to even not share needles and equipment with their partners because they want to protect the relationship. So all these issues need to be taken into consideration in designing HIV prevention interventions. And this is a study that was published only a few months ago in New York, about prisons in New York City. It's really an interesting study, included around more than 1,500 survey with women, and they did in-depth interviews with 950 women. And really this is summarizing the life of women in prison in New York City, in New York State. As you see here, women are not making a lot of money, $800,000 on average. Before they got to the prison, 41% of them were unemployed, 62% people of color in the prison, 43% did not have a high school diploma, 39% has a serious mental illness, 75% of them reported violence from their partner, more than 50% of them had a chronic illness, prevalence of HIV 12%, 17% of them had HCV, and many of them are mothers, they had children before they incarcerated. So really this kind of survey that has been done recently shows the life of women in the prison and the social determinants that really of risk of HIV. We talked about women accessing reproductive health, and this report really highlights that the women don't have access to reproductive health in the prison. They were calling for help to help them to access reproductive health issues. I know I have 10 minutes, and I have to talk about HIV interventions in 10 minutes, so I'll try my best. This is a study that, or a systematic review that shows where we are with HIV prevention intervention with women in prison. This was a nice systematic review paper. What the review paper said that there are only, since the start of the epidemic, 37 HIV prevention intervention studies that conducted in the prison. Most in the prison or in alternative to incarceration program. Most of them were in the prison and less in the community supervision programs. Only 12 of the 37 included women. And when we look at the type of interventions that were provided, mostly are psychoeducational, motivation interviewing, peer-led interventions, HIV testing and linkage to care, some pharmacological treatment like methadone, access to methadone for people at drug treatment as prevention, not including couple-based HIV prevention. We heard about the interest of couple-based, and I have been working on this type of research. No structural interventions that I mentioned, all the social determinants that need to be addressed. None of the study focused on the combination of drug risk and sexual risk behavior, and rarely there are screening of IPV. There is a need to screen for IPV, especially in community supervision programs. We know there are evidence-based interventions that need to be taken into the community. When I talk to you about Project WINGS, it's a brief intervention that we designed and tested in New York City. It's one session on IPV screening, safety planning, referrals, and linkage to care. And the intervention is one session, the same session is delivered by a case manager in the community supervision programs or delivered by a computer. And because we need to come up with evidence-based solutions to this issue, and especially screening of IPV is so critical. It's a pilot study, so we randomize women to either one of the interventions, and then we follow them up for 3 months to see if the intervention works. And what we found, disclosure of HIV didn't differ between women using the computer or women using the case manager. But we found that disclosure of IPV is really high, 47% in the past year. And we also, we learned that in this intervention, either in computer or non-computer, help women to link to care, to learn how to stay safe, and find people that can help them in the community. The other intervention that I designed, it's called Project WIHS. It's more sessions, also delivered to women in alternative to incarceration programs. Project WIHS is a group modality. It's 4 sessions, and I call it triple risks, including sexual, drug, and IPV intervention, addressing all the issues that I mentioned earlier. And also I deliver it in 2 modalities, one in group computerized self-paced intervention, and one in group modality that is delivered by a case manager. My hypothesis first was that the computerized self-paced may lead to better outcomes than the case manager is delivered, or the combination of 2 will be better than the wellness promotion intervention arm. What the intervention is? The intervention is skills building, problem solving, assertiveness skills, negotiation skills, talking about reproductive health, drug risk behavior, using safety planning and referral to services, HIV testing and linkage to care, and also goal settings for risk reduction and IPV risk reduction. The intervention is a randomized controlled trial with women randomized in 3 arms. The arm that is intervention with computers, intervention with a case manager, and wellness promotion in a arm. And we followed the women for 1 year. As you see, attendance rate in the sessions was quite high, and retention rate in the follow-up after the year is also high. Why I came up with the hypothesis that a computerized self-paced intervention is better than this case manager delivered intervention, because when we designed the intervention, I came up with the intervention that where interactive games with high-speed graphics are used to increase condom use, And also we use 4 role models in the computers to deliver the messages for the women, and women who talked about their own experiences. And also what the women loved a lot in this intervention is that they can track changes over time in the computer, and also they can print what they found at the end of themselves and learn about themselves, but what they can do also change them over time. They can go back to what they write and change and make it changes. And I'll give you an example. First, these are the 4 role models that the women, we use it through all the sessions. These role models talked about their own experiences, and each of them had an experience in being in prison, in and out of prison, and the women could relate to the stories of each woman. This is like one of the exercises in the computers where women can identify who they can help them, who cannot help them, but through the process, they also can put other people in trash. They can trash people that they don't like. And there were cases where they trashed them and put them back, but at the end, this exercise really helped the women to get engaged. The news is that we did not see a difference between the 2 modalities. Both worked well, and when we combined the 2 together, compared the wellness promotion, as you see here, we see 28% reduction in the number of unprotected sex with the primary sex partners. And we also learned that the women in both intervention increased consistent condom use. One good story is that the intervention is one of the only interventions that reduced not physical violence, but sexual abuse. Most of interventions did not help women to reduce sexual abuse by their partner, but this intervention really reduces at the end of the year, either in the computerized cell or the case manager approach. They did well in reducing sexual abuse. My other intervention is working with couples. I have been working with intervention with couples for more than 10 years, and I don't have time to share with you a number of studies, but I want to give you good news that this intervention was published in 2011 with 282 drug-involved couples from New York City, where the intervention addresses the sexual abuse, IPV, gender-based violence, gender role, gender expectation, communication skills, and safety planning, where we bring the couples together to learn about how to stay safe. What we found, the hypothesis whether was tested in this intervention, whether the couple risk reduction when you bring the 2 together is better when you deliver the intervention to one person. What we found at the end of the 1 year, that there was 41% reduction in incidence rate of unprotected sex when the couple came together, compare whether the intervention was delivered to one person. And we also found that there is significant reduction in injection drug use and in sharing needles among the couples when they came together than when the intervention was delivered to one person. Now, I'm so excited to say that I'm implementing a study in probation. It's called Project Protect and Connect for men, where the men recruited their female partners. We are facing a number of challenges. Men are so excited to be in the intervention, but women who have no history, their female partners who have no history of drug use, no history of incarceration, they're having a hard time to engage with their partners in the intervention. However, when we bring them into the sessions, they get engaged and get involved in the intervention, and they're really very exciting engagement in the whole intervention. So far, we have 160 couples engaged, and this is an implementation science intervention. We're not only looking at the outcomes from the participants, but about the systems, how the systems react to bringing such intervention into probation sites, how probation officers reacting, how the administration's reacting to the intervention, and learning about barriers of implementing such interventions. Because I have responded to the question whether or not an intervention with couples worked, and it works, but now how we can take it to the implementing and scaling it in probation sites. I really love couple-based HIV prevention intervention. And why I do think that it's an important one, because it's allow us to bring the 2 together and talk about not only how to reduce risk, but about healthy relationship, how you can build healthy relationship. And also by doing couple-based HIV prevention, we place the responsibility on the couple and not on one person. And I have to tell you, the minute they come to the first session, they want to stay in the session and they don't want to discontinue the intervention. I have less than 5 minutes, and I want to say that in terms of biomedical prevention intervention, I have to say a few words. We talked this morning about access to treatment and test and treat. Overall, only 40% of the US jail and prisons offer HIV testing. PrEP has not been even evaluated or talked about it, and STI treatment is really rarely delivered in the criminal justice system. Adherence, although the news is that adherence is better in prison than outside the prison, however, remains very low, as you see here, from 32% to 84%. What worked in the prison is directly observed therapy, worked well, and also case management before people leave the prison worked well. I have to say that I'm advocate of bringing harm reduction treatment into prison. It's going very slow. We're fighting to bring it in different countries, but in the United States, we still have not done it. There are only 55% of prisons offer methadone in 50 states, and mainly for pregnant women or for chronic management and acute opiate withdrawal. And however, the good news that in Connecticut and in Rhode Island, we see more harm reduction programs integrated into prison, which is really excited, and we hope to see it in New York. So in conclusion, we talked about risk environment, social determinants. However, when we think about HIV prevention in prison, we remain to focus on the individuals, on the couples, and less on structural issues. We need to be focusing more on human rights issues. We need to bring more on the macro level, the gender issue and the stigma. We need to do more interventions on employment and access to employments. I do work on microfinance, asset building, and vocational training in different countries. We try to get funding to the United States, never succeeded. The reviewers don't see it, and we have evidence here too from my colleagues, Susan Sherman, who tried to do more microfinance work with women here. Easy to get funding to do it outside United States. We really need to advocate for access to housing for women, because it's a major issue not having access to employment, and combination prevention is really important, and we have talked about it this morning, and I hope to see it more implemented in the criminal justice system. More attention we need to pay for sex workers in the prison and women who have sex with women. We don't know much about these populations, and they need services. And I do believe strongly we need to bring men and women together. We need to be thinking about couple-based interventions, as I described earlier, and scaling up and implementation science issues need to be taken into scale into the criminal justice system. And finally, I want to thank you and thank all the men and women who participated in my studies. Thank you. Absolutely. The major really helpful skill that they learn are communication skills and safety planning. There are a number of women who felt like the safety planning strategy helped empower them to start saying no and finding the right time to say no, and the communication skills. The skills building on communication skills was done in every sessions. In every session, the safety planning is done, in fact, at this baseline. We introduce it.
Thank you for sharing your work with us. I think it's fantastic that the participants
question, but what strikes me in listening to you describe it is we are intervening on women. Why can't we intervene on them and say, we're going to intervene on your behavior because here's what you're not doing right? And isn't that going to be more effective in the long run in stopping violence against women than teaching women how to avoid those risky partners?
This is a great question. I think we need to intervene in men and women, and my work with couples is based on we need to intervene with men too. But I totally agree with you. We need to do more with men, and if you look at evidence-based interventions with men alone, there are very few. Among the 37 studies that were mostly with men and 12 with women, but we need to do more with men. I fully agree with you. We need to focus on men. Okay. Yeah.
And jails are generally short stay.
Yes.
So have you thought about extending your probation intervention to jails and thinking about sort of that intervention right before women are released?
Thank you for your question. In fact, only last week, the mayor of New York City raised the question about how many people are in jail, and we need jails, and we need to focus on them. And it's a really great opportunity to do it. I have studies. I didn't have chance to do it. There is a study was published maybe 10 years ago where we work with women in jail and continue working with them in the community to integrate them back into community. But I think we need more. Not much has been done in jail, and it's a great opportunity to start there. No, we have a different study with same-sex couples. We do have a different one. I didn't present it.
Okay. And in any of the studies with HIV and from the prisons, was IPV introduced in any of the reentry services? Rarely in the services that are currently taking place in. They really not much. In fact, 2 weeks ago, the commissioner of New York City came to Columbia, and we had a meeting where we presented strategies of introducing IPV as a screening tool in all probation settings and all community supervision programs. And we are planning, hopefully, to take WINGS, the screening, to put it in all the community supervision. It's not, and in fact, unfortunately, probation officers, and I didn't have time to talk about when we implemented the work and how we worked with probation officers, they're not asking the questions, nor they will ask the questions. So that we have to find, and we don't have time to talk about it, but I'll be happy to talk to you about a vision of how we're scaling it up into community supervision, because we have to work with community service agencies to deliver interventions about IPV into probation sites. And finally, just have you attempted any of your interventions locally? Now New York is local, but I mean you're in Baltimore and Maryland.
We have not. In fact, I presented the same talk in Boston recently, and as a result of the presentations, we are in the process of trying to figure out ways to take this to Boston and to Connecticut, but we have not taken it yet to other places, and I'll be happy to talk to you more if it's interested. I can share with you the interventions. Yeah.
Did you look separately at women who have sex exclusively with women and women who have sex?
Yeah, I expected this question and I didn't want to answer it, so I want someone to ask me this question. So the IPV among women who have sex only with women is lower than if the women have sex with women and men. Yeah. Good debate to have, right? Yes. And we're trying to explore it, but we're speculating that because they have relationship with women, the men
trying to figure out ways to abuse the woman to stop her from having the other relationship. So this speculation, we don't yet know, but more work needs to be done.
Thanks. This is so fantastic. I'm very curious about all of the work on IPV and GBV screening and brief interventions. Getting the buy-in often in various settings is really difficult. We've seen that in the health sector. We've seen that in other places. And I wonder, you've been able to do this so successfully, it seems, in the criminal justice sector. What is what's the hook? What do they find compelling about it, such that they're able to really implement?
I agree, it takes a lot of time, but at our center at Columbia University, we have a justice center. A justice center is run by ex-offenders, people who have been in prison for 20 or more years, and people who are connected to the community, and they know how to work with the community. And through their lenses, through their work, through their engagement, we were able to get into the community. And when we go to the community, people listen to us because we know what we're talking about, and we have people who have gone through the experience. The commissioner at Columbia, the criminal justice, likes the idea that we have people who understand the issues. So that's really why we get into the community and able to deliver this kind of interventions. So I'm telling you, at this point, we can go any place because of my colleagues at the center. Yeah. Mm-hmm.
And just the association with HIV and other STIs in that population.
As you notice, our work is with, all like the average age is 30, and we have not worked with younger age, and we should. Okay, thank you.
Thank you.
So I had the great pleasure of introducing our keynote speaker, Dr. Karen Hoover. So I can say that I met Karen last night, and she's a kindred spirit. She's had a remarkable career as an OBGYN and has done sort of an alternative pathway, but I'm always glad to hear that we have OB-GYNs sitting at the table. So Dr. Karen Hoover leads the Health Services Research for Prevention with Negatives team in the Division of HIV/AIDS Prevention at CDC. Prior to joining DHAP, Karen was a health service researcher in the Division of STD Prevention at CDC. She's authored more than 100 publications and abstracts. Her current research interests include HIV testing and linkage to care, biomedical HIV prevention, including pre- and post-exposure prophylaxis, male circumcision, elimination of maternal to child transmission of HIV and syphilis, the U.S. HIV and STD healthcare safety net, HIV and syphilis diagnostics, and development of novel models for sexual and reproductive health services. Karen received her MD at Boston University School of Medicine, and then she came here to Baltimore to do her OBGYN training at Johns Hopkins Hospital. She went to practice for a couple of years and then decided to come back to the Johns Hopkins School of Public Health to actually become a clinical trialist, she mentioned, and then followed her husband down to Atlanta where she works for the CDC. So it's my pleasure to introduce Karen, who's going to talk about sort of one of the game changers in HIV prevention.
So, good morning, and thank you so much to you, Dr. Decker, and to Dr. Anderson, who's not here, for inviting me to speak at this year's symposium. It's really, really an honor to be here. So I'm going to really switch gears and talk about the biomedical end of HIV prevention. And I'm going to talk about pre-exposure prophylaxis PrEP that I think you all are familiar with, to prevent acquisition of HIV infection in women. And it's, as you know, a really exciting new biomedical prevention tool. And
as it became available really last year, it really marked a paradigm shift in HIV prevention. The use of PrEP in women can give them control to remain HIV negative, and I think PrEP is to HIV prevention perhaps as oral contraceptive pills were to contraception. It really marks the beginning of a new era, and actually when we have discussions, we often find ourselves comparing PrEP to contraception, to oral contraceptive pills. There's like a lot of analogies. I'm going to today talk about the risk of HIV among U.S. women. I'll go through that fairly quickly because oh, thank you, because I think we've had some really good overviews of morbidity. And then I'll talk about biomedical HIV prevention for women with PrEP, implementation of PrEP throughout the United States, which is a very, very big challenge, and then some research gaps that we need to support implementation. And I think others have mentioned it, but two other highly effective biomedical HIV prevention interventions are, of course, TASP, treatment as prevention, and non-occupational post-exposure prophylaxis, NPEP. And I'm not going to speak about them today in detail, but you need to be aware of them because they're also very powerful HIV prevention tools. And really, optimal prevention is prevention that uses more than one modality. By combining prevention methods, we can achieve the greatest prevention. So now I'll talk about HIV infection among women in the United States. And this slide shows the number of new HIV infections among the top 8 affected demographic populations in the United States. These are defined by their sex, their race, ethnicity, their behavior, such as sex, a sex partner, or injection drug use. And I think you can clearly see on this slide that the largest burden of disease clearly is among MSM, and especially MSM of color. But women also bear a significant burden, and while the diagnoses have been decreasing in women over the past several years, women accounted for 20%, about 9,300 infections of the estimated 47,000 plus infections. And I think people have pointed out, previous speakers, that most of this is attributed to heterosexual transmission. But I think, it really bears mentioning that in the United States, we're starting to see the emergence of HIV, an HIV epidemic in injecting drug users. And I think I was telling my colleagues last night, in Indiana, in southern Indiana, there is an HIV outbreak related to injection of prescription opiates. And about half of the people in that outbreak, they're women. And so I think we do always need to bear in mind that there is significant transmission, and perhaps an increasing proportion in women in the future might be related to injection drug use. And I'll talk a little bit more about that. So I think you guys have seen this slide. It shows, I think it was in a couple of other talks, it's a CDC stock slide. It's a really great slide because it shows that while black women comprise only 13% of the U.S. population, they are disproportionately burdened with 63% of new HIV diagnoses. And I included this graph just to show you that these racial and ethnic disparities in the diagnosis of HIV, they do persist across geographic regions in the U.S. It's not all coming out of the South and the Northeast. It's kind of dispersed. And so given that most HIV infections are overwhelmingly in MSM, and MSM largely have sex with other men, why are there so many new infections in women? Why are so many women at risk of HIV infection? And I've listed some of them here, and I'll discuss them in a little bit more detail. I think it's really very much related to the social and sexual networks that women are in. I think many women are unaware of their male partner's HIV risk status. I think that there are some high-risk sexual behaviors that women have increasingly been engaging in over the past several years. I think we do know that women oftentimes have a lack of control and really aren't always successful in negotiating other methods to protect themselves that might require their male partners to have a key role. And then finally, I think sexually transmitted infections are also a very important factor. So this is a network diagram. I just love this network diagram. It came from a study by Hurt and colleagues from North Carolina. And the people in this network were from an investigation, a DIS investigation of a black MSM outbreak in North Carolina. And I'm sorry, I don't know how very easy it is to see, but if you look really carefully in the circled areas and probably in some areas outside, the little open triangles are uninfected women. And you can see that these women have, like many sexual partnerships with MSM, who have both acute, which are the little red circles, or chronic or recent infection, which is red and yellow. Women are part of these sexual networks. And I think it's really apparent when you see these sexual connections that these women are most definitely at risk of acquiring HIV infection. And in fact, women often do choose partners within their community. You've all heard of assortative mixing patterns, where women date other persons who are in their community. And so if the women are in a population or a geographic location where there's a high prevalence of HIV infection, their risk of exposure to HIV during sex is really very much increased. And as I pointed out, women might not be aware of their partner's HIV status. And I think this was really probably the case with many of the women in this network. I'm not sure they knew their partners were infected. And so I think in addition, even if these data come from Partners study, and I believe in this particular case, the men and women were in discordant relationships and they were receiving PrEP. And I think it's just really nice to demonstrate that even with protection in a relationship, whether it be TASP or PrEP, men and women both do have sexual relationships outside of their primary relationship. And this graph is great because on the left you can see that the couples were still having sex with their primary partner, but the graph on the right shows, and I think the arrow is where unblinding of PrEP status happened, that couples felt safe to have outside relationships. And that does bring risk because if they're having outside relationships, they might not necessarily know the status of that partner. And so the risk of acquiring HIV infection does vary with the type of exposure, as shown in this table. This is from CDC's website. It estimates the risk of HIV by I think it's per 100,000 exposures, but I'm sorry, I've got 10,000 here. And we can see that, we know that women really are at risk of acquiring HIV because they're typically receptive partners, and receptive intercourse is always associated with a higher risk. You can see that with vaginal intercourse, the risk is 10, but with receptive anal intercourse, it's substantially higher, 50. And this is really concerning because these data, which are from the National Survey of Family Growth, NSFG, show that among U.S. women, anal sex has become common. And these data are not the most recent. I believe those haven't quite been published yet. So we expect that actually the reported anal sex rates will be even higher. But you can see that women who have anal sex in addition to vaginal sex, it's as high as 40% in some of the age groups. And so given the increased transmissibility of HIV through the rectal mucosa, this is actually a concerning behavior. And I think I saw this on Janelle's slide as on her research agenda to understand the risk of HIV with anal sex, and it's also on ours. We're going to be doing some studies to try to assess a little better. Okay, and so, but we know that condoms, they're very highly effective in preventing the transmission of HIV infection, but only when they're used consistently and correctly. And in relationships, I think we all know that women lack the control that's necessary to prevent an exposure, they're sometimes not able to negotiate safer sex practices such as condom use that require participation of their male partner. And so PrEP, is an option that can help with that. Sexually transmitted infections increase both the risk of transmission and acquisition of HIV, and although they're really common, they're often undiagnosed because they're usually asymptomatic. And many studies have found that routine asymptomatic STD screening among men and women is quite suboptimal despite recommendations. And I like this study. This is from one of my colleagues at CDC. He looked at surveillance data in the state of Florida for I believe a 12-year period, and compared women who had STIs to women who did not to assess their rate of seroconversion to HIV. And you can see that he found with syphilis, there was a very high conversion rate, 598 per 100,000. With gonorrhea, also pretty high, 171 per 100,000. Compared to women who never had an STI, where the rate was only 30. So, clearly demonstrating that STDs are, in fact, a risk factor. But I think a really important point to make is that in Florida, women with STDs were only a small fraction of all women who seroconverted, 2,000 out of 20,000, only 10%. So that leaves a lot of women in whom other factors were at play in HIV transmission, and really underscores how challenging it is to identify women who I think could benefit from HIV prevention measures. I think we have a really hard time doing that. And so I'll talk a little bit about PrEP. The FDA approved Truvada, which is tenofovir disoproxil fumarate TDF, and emtricitabine for pre-exposure prophylaxis in July of 2012. And 2 years later, CDC published its PrEP recommendations. PrEP is just a really powerful new tool, as you know, for prevention. And it's interesting that, and I'm going to show you some uptake slides in a little bit, but from the time between FDA approval and prevention, we didn't have a lot of traction with PrEP, not a lot of interest, not a lot of media coverage. And on the day the recommendations were published, we think the world changed. We suddenly, PrEP became part of everybody's conversation. It was very much talked about, key topic. And as a matter of fact, on the day of the guidelines release, I think we made the top half of the New York Times. We were above the fold. It was just a really special day for us at CDC, and the momentum just continues to grow. So it's really very exciting. Why are we using Truvada? Truvada is a medication that's, I think it's called Viriad when it's used for non-PrEP, and it's marketed by the company Gilead, and it's used as one component of several HIV treatment regimens. And it was selected in this case as a PrEP agent because it has some really great characteristics that make it a really ideal PrEP agent. It's co-formulated tenofovir and emtricitabine, as I've told you, so it's a single once daily pill. Both of these ARVs have long half-lives, very long half-lives in the plasma, up to 17 hours, but even longer intercellularly, where they exert their effect, as long as 60 hours. And although we don't like to say they're forgiving of imperfect daily use, because we truly recommend, daily adherence to PrEP, they are, in fact, because of their long half-lives, forgiving. And I think most of the PrEP numbers that you see published really represent the composite of a range of adherence. And basically, if people take their pills 4 times a week, they have pretty good coverage, maybe 70-ish%. For people who take their pills every day, the effectiveness is in the 90s. So it's a truly effective medication. And then finally, Truvada, with its emtricitabine and tenofovir, are really great for protecting against sexual exposure. They have very high tissue concentrations in vaginal and rectal tissues, which are, of course, common sites of exposure. Interestingly, when you start taking PrEP, your rectal tissue concentrations go up pretty quickly, and you reach, I think this is some work that Craig Hendricks has done, you reach steady state with tissue levels of tenofovir in 7 days. For women, it takes about 21 days. And I think this is maybe only but one factor that perhaps could explain some of the trial findings, but something to bear in mind. Okay, so I want to just really quickly review the clinical trials that provided evidence of oral PrEP efficacy, and it was demonstrated in the 4 studies that you see highlighted in teal. And all of these studies included women except IPREX. IPREX was a study of MSM, although it did include transgender women. And you can see when tenofovir was detected in the blood, indicating good adherence, you can see that these medications were really highly effective among men and women who took them. I do want to point out that the Bangkok tenofovir study looked at a population of injection drug users, and it did not look at Truvada, only tenofovir, but was also highly effective. And interestingly, in this study, I believe participants had a choice of doing DOT or taking medication home with them, and they were allowed to switch back and forth between groups. I think a lot of us are surprised that the efficacy would only be 0.74 with DOT, but I think we have to remember there was a lot of take-home trials or vials that went along with it. The 2 other studies that enrolled women, FemPrep and Voice, they're highlighted in purple, as you know, failed to demonstrate efficacy. And we really do think this is because of low adherence to taking the medication daily. And really, because of these studies, I think it's become a myth, even in the United States and certainly in the international setting, that PrEP is ineffective in women, but we know that this is untrue. In the other trials highlighted in green, we had women who, when they took their PrEP, were protected. And so it was an adherence issue, and I think there's a lot of really interesting discussion and work that has gone into understanding why adherence has been so problematic for women, and I think I'll talk a little bit more about it when I talk about the topical microbicide trials, because I think the adherence issues kind of are in common with those 2 routes of So I just want to go over the indications for prescribing PrEP. We all know that it's recommended for heterosexual women who are at substantial risk of HIV acquisition. And I think we have a little bit of trouble at CDC always defining what we mean by substantial risk. But our definition is here: history of inconsistent or no condom use, having a positive partner, and includes women who are intending to become pregnant who have a positive partner. Anybody who's had a recent bacterial STD, I think we put a window of 6 months on it, although I think really within the past year is a reasonable indication for offering PrEP. People who have a high number of sex partners, of course, people who engage in commercial sex work. And I think for all of these recommendations, it's kind of in the context of being in a high prevalence area or network. And I mean, a really great example, I think, is chlamydia as a bacterial STD. I think Janelle knows how incredibly prevalent chlamydia is among women, and yet very few of those women are really at substantial risk of acquiring HIV. And so I think that's an example of a woman with a bacterial STD whose network or community should be considered in making a PrEP prescription decision. And then I also really want to point out, and I think many of us forget, that PrEP is also recommended to prevent transmission with injection drug users. And so PrEP is recommended for anybody who has an injecting partner who is infected, anybody who is sharing injection equipment, whether it be cookers, needles, and anybody who's recently been treated for their substance abuse addiction, but they're currently injecting. They're at very high risk of becoming infected. And so this is the continuum of PrEP care for prevention with PrEP, and it highlights some of the steps that are required for successful HIV prevention. And I think these steps can serve both as important points for assessing how we're doing with PrEP with a patient and for targeting interventions to improve service provision. And I think it's really important to point out that when initiating PrEP, it's very important that women be screened with the most sensitive tests possible. And in the current time, that means a fourth generation HIV test. Now, alternative regimens do include using pooled viral RNA testing accompanied by a negative third generation antibody test. But we really need to be very careful that we can rule out acute infection. And this is important because if we initiate Truvada alone and we have unrecognized, undiagnosed infection, then we're really providing that person with suboptimal ART. And we know that when we provide suboptimal ART, that's when we risk selecting for mutations and for resistance. So we very much have to be very careful that we aren't missing that. And then I think our next step is that we need to, when we're with a patient in a clinical encounter, assess her risk of HIV. Is she at substantial risk? And this is just really challenging because I think we don't entirely know who we define as being at substantial risk. But it's also really hard for providers, to have a very sensitive, nuanced discussion of sexual and injecting risk behaviors. That's a hard conversation for both the patient and the provider. And I mean, some providers are very good at those conversations. I think OBGYNs are very comfortable, very skilled at discussing patient sexuality. But PrEP is kind of meant to be delivered from a variety of settings and by a variety of provider types. And primary care doctors, sometimes pediatricians, they're just not as used to having those conversations, so that can be a barrier. And then after prescribing PrEP, that's kind of the easy part. Then we have to support adherence, and adherence support is, I think, a topic of a lot of discussion, and in a very challenging, area that needs a lot of research. We need to have good, effective interventions. I'll tell you a little bit more about it later, but we have a study, an implementation study of PrEP and FQHCs, and we're in this study assessing our patients as part of routine clinical care for adherence support. And some of the modalities we plan to use to support adherence are these little gadgets where you can put a little flashing light cap on the pharmacy bottle and the little pill bottle, and it lights up when the patient's missing a dose, or iPhone-supported apps, but these are just but a few of many potential options that could be used to support adherence. And then finally, it's very important that patients come back. They should never be given more than a 90-day supply. And in fact, when you're starting patients out, you might want to give them a few, smaller quantities to get them to come back, to talk to them about adherence, to have a chance to see how they're doing, to help them manage side effects, to assess their behaviors. But at least every 3 months, they need to come back for their refill. And they need to be tested for HIV and for STIs, also for renal function, because we do know that in HIV-infected patients, we've seen some issues with altered creatinine clearance with tenofovir, although not in PrEP patients. And it's also a chance to just see how they're doing, support the adherence, and to do a risk assessment and to conduct additional counseling and risk reduction, to deliver risk reduction messages, to encourage condom use, because PrEP is part of a more comprehensive prevention package. And so this slide shows the recommended care for patients when they initiate PrEP. They have to have a negative HIV test, as I think I've told you. You want to also assess them for signs or symptoms of acute infection that might be present even before they have biomarkers in their blood. They have to have normal renal function. They can't be taking any medications that could be contraindicated. And it's really important that their hepatitis B status be known, because Truvada is an agent that's used in many hepatitis B treatment regimens. And if a patient is started on PrEP, I mean, there aren't any deleterious effects for the hepatitis B infection, but it tends to suppress the virus. And then if a patient stops PrEP, they can have very severe rebound viremia and become quite ill. So hepatitis B is not a contraindication for PrEP, but the provider must be aware. And when a patient stops PrEP, this has to be done usually in conjunction with an infectious disease doctor, because managing the switchover can be complicated. And then, as I've mentioned, every 3 months, patients need to come back. They have to have their HIV test, of course, a pregnancy test, STD testing at all sites of exposure, so genital and non-genital testing, and then at the first 3 months and then in every 6 months afterwards, renal testing to make sure their kidneys are holding up under the potential toxicity, although very low, of tenofovir. So I just want to say a little bit about HIV resistance. We do know that it's been observed in persons with, really in PrEP patients, only if they had undiagnosed acute HIV infection at initiation, or if they seroconverted while they were taking PrEP. And so that's why it's so very important that the HIV testing be conducted at follow-up visits. And so just underscoring, I think it still is a really big concern that we hear from providers and people, the concern about resistance with PrEP. But it's really it's not a significant concern if recommendations for initiating and continuing supportive care for PrEP are followed. And just a quick note that when resistance typically happens with PrEP, it's usually to the emtricitabine component of PrEP, which the strains that have that resistance tend to be a little bit weaker, and over time they tend to be, crowded out by wild-type virus. Of course, you can switch patients to effective alternatives, and they're fine. So I want to talk about PrEPception just really quickly, because I think Janelle covered it, but these are some of the methods that serodiscordant couples who are trying to conceive might want to try. They have several options. They're listed here. I mean, of course, when you're trying to conceive, you don't use condoms. And so you have to take some measures to prevent transmission of HIV. And some of the things that an HIV-positive woman who's trying to conceive with an HIV-negative man could consider is, of course, TASP. The infected partner being treated is very effective. And limiting conception attempts, monitoring ovulation, and trying to conceive around the times when it's most likely to be successful. Intrauterine insemination or intravaginal insemination, of course, STD testing and treatment to eliminate that as a cofactor in transmission. Male circumcision's very effective for protecting the HIV-negative man, but that's a whole other discussion, and we're not going to recommend, male circumcision requires a long healing period. This is, I think, in the context of a more global conception conversation. And then, of course, PrEP, which I'll talk about more in a moment. For HIV-negative women, their infected partner, of course, can have ART. TASP is so very effective. Limiting conception attempts, sperm washing, which is quite expensive and not always available, along with IUI, IVI, or intracytoplasmic sperm injections, STI testing and treatment, and PrEP. And so PrEPception is a very important tool, and to prevent infection in a female partner, an infected male partner has to have reliable adherence to his ARV therapy to keep his viral load suppressed. And just relying on this, on the HIV positive partner to take his medication and be virally suppressed, doesn't always provide complete assurance that he won't transmit his infection. So PrEP can offer this protection along with TASP. And I think it was an Olay add-on to the Partners Prep study that was at Corey. Do you remember, Janelle, what the name of the study was? But they actually looked at people who, where one partner was on TASP and the other partner was on PrEP, and they virtually eliminated transmission. So they do really work well together. But because women are more susceptible to HIV infection during pregnancy, they might want to continue PrEP throughout the pregnancy. And as we know, if you do become acutely infected in pregnancy, the risk of transmission to the infant is a lot more marked than with existing infection. And so PrEP's also an option for the negative male partner of the infected woman. And we do have really a lot of really ample data that support that PrEP is safe and effective during pregnancy. I think Janelle mentioned, women became pregnant in clinical trials and then they stopped their PrEP, but still it provided some data for us of outcomes in those pregnancies that have given us reassurance that PrEP is safe in pregnancy. And we've used tenofovir and emtricitabine as part of ARV regimens in pregnant women for many years. And, we have had very good outcomes. And so we think that they're fairly safe and effective in pregnancy. And even though we didn't have compelling trial data when we were writing our CDC recommendations, we received HHS clearance to include them as an indicated population because of the reassuring history that we have with these medications. And so I think, for non-pregnant women, it is challenging, and I think we'd really like to have a lot more research. Dr. Dawn Smith, who I work with, has developed some really nice little simple predictive tools for substantial risk that can be used in MSM. And more recently in injecting drug-using populations, but we're kind of struggling with data inputs to generate such a little predictor for women because, there aren't a lot of good cohorts of seroconversion, although perhaps I can collaborate with some colleagues here to get those data. But we'd like to be able to create little scales that can assess risk. But in the meanwhile, I think who should we be considering PrEP for? Who should be offered PrEP? Well, probably any woman who comes to you as a provider and is concerned about HIV acquisition. If she's worried that she's going to become infected, you should have a conversation with her about PrEP. Certainly women with HIV-positive partners. A woman who's in a relationship that isn't mutually monogamous might benefit from PrEP. She may not necessarily know her partner's status if he has other partners, and so that's a way for her to protect herself. Certainly women who live in communities or are part of networks with a high HIV prevalence, and I think this is probably a key factor in why we're seeing some of these disproportionate rates among Black women because of the networks in the communities. And of course, women with STIs, especially syphilis or gonorrhea, these serve as both biomarkers for risk and they are cofactors for transmission. And then I think a hypothesis that needs a little data to flesh it out a bit is that women with high-risk behaviors such as anal sex, especially if they're in a network where there's a high prevalence, are probably going to be at increased risk. So I want to mention the vaginal microbicide trials that had offered really great hope to us for women-controlled topical PrEP. You all know that Caprisa 004 found a 39% reduction in HIV acquisition among women who used the vaginal, 1% tenofovir vaginal gel. And very nicely, along with that, was a 51% reduction in transmission of HSV2, could be a cofactor mediating some of the reduction in HIV transmission. But then VOICE, which looked at tenofovir gel along with oral regimens, and most recently FACS 001, both found that there was no effect of topical vaginal microbicides in transmission. And it's really because of poor adherence. And we saw poor adherence by women in these trials, which were largely in sub-Saharan Africa, both for oral PrEP and topical PrEP. And And, you know, there's been some really interesting qualitative work that has been done in the wake of the VOICE study, and I think there's a lot of factors that emerged. I think the women, you know, were telling the researchers, and by all of the measures available to the researchers, pill counts, you know, product counts, it looked like adherence was very high, 90%, but it turns out that they were discarding the pills or giving them to others, throwing the gel away, and just really didn't want to tell the providers that they weren't using the product. Why was that the case? Perhaps because they wanted to please the researchers. You know, they were part of this community. They were getting really excellent health care and all of the benefits that go with that. They were also being compensated for participation in the trial, and the compensation was very significant for, you know, the region and the community they lived in, and so they, you know, didn't want to risk their compensation, even though I believe they were told they could continue in the trial. They just didn't want to risk it. There was also a lot of concern associated with taking the medications. You know, there's a lot of stigma if you're taking pills for prevention. It's kind of hard to convince your partner and your community that you really aren't infected, that you're trying to prevent infection. And I think a really nice blog that I read by Auerbach, she mentioned that, you know, in the United States, we're a pill-popping culture. We don't think anything of it. We take our OCPs every day. We have no problem with that. But in Africa, most women use injectable contraception, and taking, you know, prevention isn't as an ingrained notion as it is here. And taking a pill every day for prevention was just not the cultural norm. So, you know, I think we're all very sad about the topical PrEP trials. I think it's we have all but abandoned the approach of vaginal gels, and we've moved on, as you all know, to ring studies, and we have great hope for the ring studies. We'll have to see how we do with adherence with those studies. I think in the United States, I'm not so very sure it would do well. You know, we've looked at contraceptive uptake. It's very, very low utilization, but I'll talk more about that in a moment. And then we do still have rectal microbicide trials going, MTN 017. It's in its second phase. So I'm going to just mention future PrEP delivery models. I think these were all talked about. For non-oral and non-topical, we have the vaginal rings coming up. And this is typically a ring, I think it's dapivirine, that's embedded in the matrix of the ring. I don't have a picture of it here. I wish I could have found it, but I know that some of the rings they're using, they have these little like little nodes, and each node can be loaded with a medication. And someone in the audience brought up, you know, co-formulating hormonal contraception in these rings along with the dapivirine. And I think that's, I don't think trials have started yet, but it's on the horizon, and I think we'll be seeing that soon. But I think we have to first see how we do with the dapivirine rings and see how acceptable it is to women. Long-lasting injectables are also in various clinical trial phases, and that's something that I think we're putting a lot of hope in domestically for the MSM epidemic, because, you know, the adherence issues can be overcome, but I think those of us who have worked in with contraception know that we have adherence issues with our Depo-Provera users. You can sometimes get the first injection, but we have like a lot of drop-off with coming back for the second. So I think all of the, you know, all that we've learned from implementing injectable contraception, I hope that we keep in mind and learn from and base our efforts with injectable PrEP agents in that context. And then, although not really in trials yet, subdermal implants, this is a picture of Implanon, it is also on the horizon. There is, I have to look at my notes because I can never get the name of it right, but TAF. Does anybody know what TAF I think it's tenofovir alafenamide fumarate. And this is a prodrug of tenofovir. And it would be a perfect agent to put in a subdermal implant. It's really a kind of a hot new Gilead drug because you can give people really low doses of it, given that it's a prodrug. And by giving them low doses, you can avert some of the toxicities, the renal toxicity, some of the bone toxicity. And then it targets the cells that are at risk of HIV infection and goes there and it's activated to the active agent. So that's a really exciting and I think hopeful option for us in the future. And someone had said with injectables, what do you do if someone gets pregnant? What do you do? Well, when you have a little implantable, you can simply remove it and stop the elution of medication. So I think there's going to be a lot happening in the future with PrEP. I think oral PrEP is just really the beginning. And so now I'll talk about implementation. PrEP use in the United States. It's low, but it's increasing. And these are data from a study done by our Gilead colleagues, and they analyzed administrative pharmacy claims data. They found the number of prescriptions increased really quite dramatically between 2011 and 2012. In this analysis, you can see that about half of the prescriptions were given to women and very few to young women. And I think I'm not quite sure about this data. I think since this has been published, Gilead has been, these were preliminary findings and with a model that was being refined. I think now they're showing that most of the PrEP uptake has been in men. I don't think that surprises us. But this is very interesting. We can see that most PrEP's being delivered by family practice, internists, so primary care providers, and a lot by mid-level providers who are doing primary care. I thought it was a little surprising that infectious disease docs are administering PrEP. Perhaps that is PEP. It can be very challenging with administrative data to tease out PEP and PrEP. And 26%, it didn't show up on here, but that's other. These are data from a study that one of my fellows, Shu Wu, has done, and she's in the process of writing it up. But it's also an analysis of administrative data, of health services data, the MarketScan database. And you can see that in our study, PrEP just starts to go up really rapidly in 2012. And 2012 is when we had the FDA approval. I'm kind of thinking that when we're really excited to get our 2014 data, we think it's going to go really high because it was in mid-2014 when the guidelines came out. But in our data, we're seeing that about 90% of the people getting PrEP are men. They're a little bit older. We don't have race and ethnicity in this data, but I would bet that they're probably white MSM, and most of them are living in cities. And so we really do have a lot of work, I think, cut out for us to try to get this really effective agent implemented for women. And so how do we do that? Well, I think we work with the providers who are in the clinical venues where women go for their care, OBGYN providers, family planning clinics. I think Auerbach's work showed that family planning clinics, many women indicated that that's where they would like to have conversations about PrEP. Primary care providers are who we at CDC are, kind of targeting as prime PrEP providers, those who come into contact with patients who might be at risk during their everyday practice. FQHCs kind of includes all of the above, and we have a study in FQHCs I'll tell you about in a moment. STI clinics, which is on my group's horizon to start, doing some models for STD clinics. I mean, if you think about it, an STD clinic is the easiest place to identify people who might need PrEP. We call it the low-hanging fruit, especially for men. I think anybody who has a rectal infection or syphilis, and really male or female, needs to have a conversation with their provider about HIV prevention and PrEP. I think, what are some of the barriers? Well, I think our healthcare providers are either unaware of PrEP or they think it's a bad idea. don't really know a lot about it. So we really do need to do some training. I think CME training. We have toolkits that were published with the 2014 guidelines that we at CDC need to do a little bit better job disseminating. But we know academic detailing is a really great way to increase provision of a service, sending health department staff to the clinics and having multiple touches with those providers to teach them about PrEP and to encourage them to use PrEP and to support it. We also have hotline at CDC, a warm line actually, that people can call to get help, providers. But I think also we need to create demand among women, and there's a branch in DHEP at CDC, Prevention Communication Branch, that just does beautiful educational campaigns, and they've largely focused their efforts on PrEP campaigns for MSM. But we really do need to target women with social marketing and educational campaigns, because when you want to increase a new intervention, you kind of need to have push and pull. And so you have to work both with the providers and the women. And this is a really nice implementation plan that Dawn put together. And it just talks about, I think, some of the activities and outputs to reach our objectives for PrEP implementation. And so I think I've talked about these, but I'll just go over them again. I think they're really useful to keep in mind. What are the barriers to implementation? And patients are unaware. They mistrust medical institutions. There are concerns about side effects with HIV medications. Patients think if it's a medication for HIV, it must be powerful and potent. And that was probably true 20 years ago, but most of the newer medications that are being used with patients have fewer side effects and are far more tolerable. There is, of course, stigma about taking HIV medications. This is true for women and MSM. I think the issue of lack of access and health insurance is one we hear constantly at CDC, but we really feel that it takes a little effort, but one that can be overcome. I think Medicaid in almost all states will cover PrEP, and most health insurance providers cover it. And for those patients who fall through the gaps, Gilead has they've recently expanded their eligibility criteria to persons who are at 500%, I think, the 500% federal poverty level for eligibility. And so there are options, and I think we were talking about it at dinner last night. Anything that a provider chooses to do, it's really best to do it in a sustainable manner. And so, Gilead can support practices with medications, but it's really best if we can find ways to have these things be sustainable with other clinical services that we provide. High co-payments are a problem. And I think, we are taking some steps in the federal government to try to work to help minimize that and control that. Healthcare providers are unaware of PrEP. They have inexperience with HIV medication, just like patients think the HIV meds are toxic and will make them sick. I mean, when I was training as a physician, I was taught that, you don't touch an HIV-infected patient. They must go to the HIV clinic. They need very nuanced, careful care. And now CDC and HRSA, we're trying to shift that back to HIV care occurring in primary care settings, and it's an upstream swim, because the messages that it's complex and nuanced are a little hard to overcome, that are very ingrained in providers. Providers are concerned about risk compensation. They're concerned about increases in STIs with patients on PrEP who won't use condoms. Although one of my colleagues says we're going to worry about increases in gonorrhea, at the expense of HIV prevention, but we do have to, always deliver to patients the message that, PrEP is but one of many mechanisms to protect yourself. And I think I've already mentioned it's hard to conduct. Okay, so now I'm just going to go quickly into research that I think we need to do to support implementation of PrEP. We're starting to do this on my team, some operational studies, so either developing PrEP programs and helping clinics to implement them, or identifying programs where it's already happening and evaluating the operations of doing this and disseminating. And then the second step would be taking the lessons learned from smaller operational studies and using them to scale up effective PrEP services on a larger scale in health systems, for example. So going from a single Kaiser clinic to having PrEP offered through Kaiser systematically. We need to be better at disseminating best practices for PrEP, so publishing, conducting workshops, educational sessions to share what works for PrEP delivery. And then I think another really important thing that we do at CDC is we monitor PrEP uptake, access to it, barriers to access, utilization, the quality of services. Are patients getting tested for HIV? Are they being screened for STIs? Those are all important things to do. I'm just going to go through these really quickly because I think I have a minute of ongoing clinical trials for new oral PrEP agents. This is, I think, a study that some of your colleagues at Hopkins are involved in. It's just looking at intermittent PrEP dosing. It's a pharmacokinetic study to just get a sense of what steady state levels look like when you don't take your PrEP every day. There have been some studies in the news, IPERGAY and PROUD. IPERGAY looked at, these are European studies, IPERGAY looked at intermittent dosing in MSM, and we're a little concerned about the study design and perhaps false reassurance that you don't have to take your PrEP every day, and so we're hoping this study will answer some of those questions. This study's looking at new agents, Maraviroc, which is an integrase inhibitor. I think we've already talked about injectables. The RING studies, both the ASPIRE trial and the RING study with results coming out. I'll bet they'll be at CROI next February. These are looking at dapivirine embedded in the RING. We've kind of given up on the vaginal microbicides, but we still have hope for rectal microbicides, and MTN 017, I think I've mentioned, we're anxiously awaiting those results. And then this is a study that my team is conducting. It's a real-life implementation of PrEP in federally qualified health centers in cities that were chosen because we know that there are high rates of HIV, the high prevalence of HIV in women in these communities, and we're really making a concerted effort to include women as well as men. And we're going to support their adherence, and we're doing a sub-study to monitor adherence to PrEP medication using dried blood spots. And along with that study, we're doing some surveys to understand the context in which the services are delivered. And so I just put this cute little pup on here, the condom puppy, because I really, he doesn't look very happy. Look at the tail, like, oh, the very stressed dog. But I think it really is just important to underscore that PrEP is just one component of a menu of more comprehensive prevention modalities. And each one of these are imperfect alone, but when we use them together, we can approach really great HIV prevention. So don't forget to call the condom dog over when you're taking your PrEP. And this is just a little hello blast from the past on the old Nelson II labor and delivery suite. It's amazing that Hopkins survived me and my buddies here. And that's it. Yes?
Quick question. I know PrEP rarely is recommended for older adults.
That's.
Who are HIV positive. However, a lot of older men particularly have problems using condoms. And, they don't have choices.
I think younger men do too, actually.
Well, I'm just saying though, but they don't recommend PrEP. It's hard for an older couple to get PrEP. Women, they say if you're a positive woman, there's such a slight chance of you infecting a negative partner, male partner. You don't need it.
Well, the risk is lower, but it's still there.
Male partner, and you can't use a condom, his negative female partner is at risk. Are there going to be any studies or anything to sort of change that, or to think about, consider the fact that older adults are very sexually active, and they need it just as much as younger?
No, I agree. There are no age limits, I think, for PrEP. And, maybe one of you guys can help me out with the age range in some of the trials. But I think PrEP would be very effective. I'm sure the efficacy is also.
You're over 50, you can forget.
Why do you think, what are the barriers? What do you think the barriers are?
I And I questioned it a lot. And I was told there were no studies available, that it was not going to be available, that because I'm the female and I'm positive, I'm not going to pass it to him. But I considered other people who were not, the male that was positive and the female that was negative, and they just are not considering.
Was this your doctor?
I asked a lot of doctors.
Really?
Not just my doctor.
Well, you just,
I question this everywhere I go.
yeah,
You know, even at the USCA conference, I
Right.
questioned several people about it. I found from some younger women that they were denied PrEP unless they were attempting to get pregnant.
well, that's unfortunate. And,
I'm just
yeah, you're just pointing out how much work we have at CDC to do with dissemination and with implementation of PrEP, because I think, I don't think there is an age criteria for PrEP. I mean, I think compromised renal function, which, is going to perhaps be more common as one becomes older, might be an issue, but, no, no. Nor should there be for heterosexual couples. Yeah. Well, no, thank you. Those comments are appreciated.
Dr. Lubin, thank you very much for the presentation. I learned a lot today.
Great.
And I can see that PrEP is very effective. My only concern is I work a lot with emerging adults, and they think that the goal is to have irresponsible sexual behavior and that you can just take a pill and everything will be okay. And from a public health perspective, my goal for the community is not to become ill in the first place.
Right.
So, that's just a comment I wanted to share as working with emerging adults, particularly around behavior strategies.
Right.
Can be very challenging
Right.
in this age.
Right, and I think those are concerns that a lot of people have about, risk compensation when you're protected from HIV. And I know my friends and colleagues in STD are very worried that we're going to see increases in a lot of the STDs. I think in the trials, and trials are never really quite the same as the real world, there really weren't increases in control groups versus PrEP groups with those outcomes. And so it just gives us a little bit of reassurance that that doesn't necessarily happen. I don't think, and I think you all probably saw in the media Truvada whore. Did anybody hear that, see that? Once again, I'm going to go back to the OCPs because, not too long ago, we had a media figure call a woman who was advocating for contraception a whore. And so, I think it's a problem that isn't, really restricted to emerging young adults. I think it's for all of us, and we certainly need to keep that in mind, but I think that's a good point. We are going to be looking very carefully at risk compensation, studying it and using markers of it like increased STDs in U.S. populations, but your concerns are shared by many.
You mentioned that women on PrEP need to come in every 3 months and do a variety of tests.
Uh-huh.
And it seemed like that could be a big burden for a lot of patients.
I think so too.
And I'm wondering if there's any evidence that is discouraging women from starting PrEP or leading to gaps where, they run out of pills in 90 days and they aren't able to come back in, or if that's stopping providers from prescribing it because they think that women won't be able to adhere to that schedule. And also, as PrEP is rolled out in other countries, maybe developing countries, is that sort of schedule going to be reasonable as well?
I think that's a really great point, and I don't think we have a lot of data about to what extent that's a barrier. It would be for me. I'd be really annoyed if I had to go to my provider every 3 months. I'd probably just call in refills for myself, but that would be very irresponsible, because the HIV test is critical with PrEP care. And we talked a lot about maybe developing some models that we could test and pilot for easier ways for people to get around that, perhaps to do, it's a little hard because you need to do, fourth gen testing when you want to look for the acute infection, but ways to maybe send a sample from home, or to just have expedited visits. And, you know, I really think as we get more comfortable with PrEP and we learn more about it, perhaps those models will change. We need to start getting some data to see what adherence looks like and what happens with seroconversion rates while on PrEP. But I think right now, you know, at the onset of it as a new modality, the more conservative, like, care recommendations really are kind of reasonable. But I think you're right. I think that's going to be a barrier, and perhaps we'll see, you know, we're looking at cohorts of women with PrEP using health insurance data. And I wouldn't be surprised if we see some drops at the 3-month mark where they didn't make it back to their provider. But yeah, that's unfortunate.
Mine is sort of the flip side of Sarah's question, which is on the other side for the screening piece. Because when I was looking at your set of risk factors, there's some that are very clearly risk factors, and there's other that I would call a little bit softer.
Uh-huh.
And I wondered if there's been any thought about taking some of those softer ones and actually developing some kind of a risk score, something like the Gale score that's used
Yeah.
for breast cancer. So has there been
Right.
thought about that? Because it seems to me there's an awful lot of effort, there's an awful lot of money that needs to be put into outreach, follow-up, all of those aspects of sort of giving PrEP that are not about reimbursement for the prescription. So I wondered about it.
Yeah, well, yeah, I think developing an easy-to-use risk score that either a woman herself could use or her provider could use, or it could be filled out in the waiting room. It's what we're trying to do at CDC. I think I've mentioned Dawn Smith has prepared a couple of really easy, like 5 or 6 question instruments that were based on prospective data of seroconversions and looking at the characteristics of those who convert, and then working with one of the talented statisticians that we have at CDC to, to turn it into like a scaled score with, sensitivity and specificity and ROC characteristics that are most predictive of who's going to seroconvert, and then using those instruments to easily identify people who could. But we've been very challenged with finding. Prospective data. We've talked with a lot of health departments. I think we talked with Miami and Philadelphia, a couple of others, and it's just really hard to get, robust data where we could do those sort of statistical maneuvers to create a risk score. But we definitely need that.
So let me ask you a further question about developing that score. Have you thought about, in lieu of getting those data right now, perhaps using expert panels or expert judgments to develop a scale?
And I think that's what the PrEP guidelines recommend. I mean, if you pull up the PrEP guidelines, there are tables of who it's indicated for, and we have things like not using a condom, having multiple sex partners.
I actually mean in a probabilistic sense. So there's a way of using sort of decision analytic methods with expert panels. Even having data where you can actually do some risk assessment based on what their judgments would be of the probability of individuals.
Oh, I actually like that.
Converting. Yeah, we did some of that years ago, looking at a measure of maternal transport and pregnancy. And it's actually a very interesting exercise because you can get, I think, some real sort of thoughtful judgments on if you pick correctly the right exercise. So it would be interesting.
Oh, I would love to see those articles because that could be very helpful for us. We're very much struggling with this issue in women. Yeah.
Wow, well, thank you. This has been just a great discussion. I want to thank you.
My pleasure. My pleasure.